The doctor-patient relationship is a central part of healthcare and the practice of medicine. A doctor-patient relationship is formed when a doctor attends to a patient's medical needs and is usually through consent. 1. This relationship is built on trust, respect, communication, and a common understanding of both the doctor and patient sides. The trust aspect of this relationship is mutual. The doctor trusts the patient to reveal any information that may be relevant to the case, and in turn, the patient trusts the doctor to respect their privacy and not disclose this information to outside parties. A ceremonial dynamic of the doctor-patient relationship is that the doctor is encouraged by oath to follow certain ethical guidelines. Hippocratic Oath, 2, 3. Additionally, the healthiness of a doctor-patient relationship is essential to keep the quality of the patient's healthcare high as well as to ensure that the doctor is functioning at their optimum. In more recent times, healthcare has become more patient-centered and this has brought a new dynamic to this ancient relationship. Citation needed. Importance. A medical practitioner explains an X-ray to the patient. The doctor is providing medical advice to this patient. A physician performs a standard physical examination on his patient. A patient must have confidence in the competence of their physician and must feel that they can confide in them. For most physicians, the establishment of good rapport with a patient is important. Some medical specialties, such as psychiatry and family medicine, emphasize the physician-patient relationship more than others, such as pathology or radiology, which have very little contact with patients. The quality of the patient-physician relationship is important to both parties. The doctor and patient's values and perspectives about disease, life, and time available play a role in building up this relationship. A strong relationship between the doctor and patient may lead to freely offered quality information about the patient's disease and as a result, better healthcare for the patient and their family. Enhancing both the accuracy of the diagnosis and the patient's knowledge about the disease contributes to a good relationship between the doctor and the patient. 4. In a poor doctor-patient relationship, the physician's ability to make a full assessment may be compromised and the patient may be more likely to distrust the diagnosis and proposed treatment. The downstream effects of this mistrust may include decreased patient adherence to the physician's medical advice, which could result in poorer health outcomes for the patient. In these circumstances, and also in cases where there is genuine divergence of medical opinions, a second opinion from another physician may be sought, or the patient may choose to go to another physician that they trust more. Additionally, the benefits of any placebo effect are also based upon the patient's subjective assessment, conscious or unconscious, of the physician's credibility and skills. 5. Michael and Enid Ballant together pioneered the study of the physician-patient relationship in the UK. Michael Ballant's The Doctor, His Patient and the Illness, 1957, outlined several case histories in detail and became a seminal text. 6. Their work is continued by the Ballant Society, the International Ballant Federation, 7, and other national Ballant societies in other countries. It is one of the most influential works on the topic of doctor-patient relationships. In addition, a Canadian physician known as Sir William Osler was known as one of the Big Four professors at the time that the Johns Hopkins Hospital was first founded. 8. At the Johns Hopkins Hospital, Osler had invented the world's first medical residency system. 9. In terms of efficacy, i.e. the outcome of treatment, the doctor-patient relationship seems to have a small, but statistically significant impact on healthcare outcomes. 10. However, due to a relatively small sample size and a minimally effective test, researchers concluded additional research on this topic is necessary. 10. Recognizing that patients receive the best care when they work in partnership with doctors, the UK General Medical Council issued guidance for both of doctors named Ethical Guidance for Doctors, 11, as well as for patients what to expect from your doctor in April 2013. 12. Aspects of relationship. Informed consent. Main article, Informed consent. The default medical practice for showing respect to patients and their families is for the doctor to be truthful in informing the patient of their health and to be direct in asking for the patient's consent before giving treatment. Historically, in many cultures there has been a shift from paternalism, the view that the doctor always knows best, to the idea that patients must have a choice in the provision of their care and be given the right to provide informed consent to medical procedures. 13. There can be issues with how to handle informed consent in a doctor-patient relationship. Wink with a frown. 14. For instance, with patients who do not want to know the truth about their condition. Furthermore, there are ethical concerns regarding the use of placebo. Does giving a sugar pill lead to an undermining of trust between doctor and patient? Is deceiving a patient for his or her own good compatible with a respectful and consent-based doctor-patient relationship? 15. These types of questions come up frequently in the healthcare system, and the answers to all of these questions are usually far from clear, but should be informed by medical ethics. Shared decision-making. Health advocacy messages such as this one encourage patients to talk with their doctors about their healthcare. Main article, Shared Decision-Making. Shared decision-making involves both the doctor and patient being involved in decisions about treatment. There are varied perspectives on what shared decision-making involves, but the most commonly used definition involves the sharing of information by both parties taking steps to build consensus and reaching an agreement about treatment. 16. 4. The doctor does not recommend what the patient should do, rather the patient's autonomy is respected and they choose what medical treatment they want to have done. An alternative practice, for the doctor to make a person's health decisions without considering that person's treatment goals or having that person's input into the decision-making process, is considered grossly unethical and against the idea of personal autonomy and freedom. The spectrum of a physician's inclusion of a patient into treatment decisions is well represented in Ulrich Beck's World at Risk. At one end of the spectrum is Beck's negotiated approach to risk communication, in which the communicator maintains an open dialogue with the patient and settles on a compromise on which both patient and physician agree. A majority of physicians employ a variation of this communication model to some degree, as it is only with this technique that a doctor can maintain the open cooperation of his or her patient. At the opposite end of this spectrum is the technocratic approach to risk communication, in which the physician exerts authoritarian control over the patient's treatment and pushes the patient to accept the treatment plan with which they are presented in a paternalistic manner. This communication model places the physician in a position of omniscience and omnipotence over the patient and leaves little room for patient contribution to a treatment plan. 17. Physician communication style. Physician communication style is crucial to the quality and strength of the doctor-patient relationship. Patient-centered communication, which involves asking open-ended questions, having a warm disposition, encouraging emotional expression, and demonstrating interest in the patient's life, has been shown to positively affect the doctor-patient relationship. Additionally, this type of communication has been shown to decrease other negative attitudes or assumptions the patient might have about doctors or healthcare as a whole, and has even been shown to improve treatment compliance. 18. Another form of communication beneficial to the patient-provider relationship is self-disclosure by the physician in particular. Historically, medical teaching institutions have discouraged physicians from disclosing personal or emotional information to patients, as neutrality and professionalism were prioritized. However, self-disclosure by physicians has been shown to increase rapport, the patient's trust, their intention to disclose information, and the patient's desire to continue with the physician. These effects were shown to be associated with empathy, which is another important dimension which is often underemphasized in physician training. 19. A physician's response to emotional expression by their patient can also determine the quality of the relationship and influence how comfortable patients are in discussing sensitive issues, feelings, or information that may be critical for their diagnosis or care. More passive, neutral response styles which allow for patients to elaborate on their feelings have been shown to be more beneficial for patients and make them feel more comfortable. Physician avoidance or dismissal of a patient's emotional expression may discourage the patient from opening up and may be harmful to their relationship with their provider. 20. 21. Physician superiority. Historically, in the paternalistic model, a physician tended to be viewed as dominant or superior to the patient due to the inherent power dynamic of physicians' control over the patient's health, treatment course, and access to knowledge about their condition. In this model, physicians tended to convey only the information necessary to convince the patient of their proposed treatment course. The physician-patient relationship is also complicated by the patient's suffering. Patient derives from the Latin patir, suffer, and limited ability to relieve it without the physician's intervention, potentially resulting in a state of desperation and dependency on the physician. A physician should be aware of these disparities in order to establish a comfortable, trust-based environment and optimize communication with the patient. Additionally, it may be beneficial for the doctor-patient relationship to create a practice of shared care with increased emphasis on patient empowerment in taking a greater degree of responsibility for their care. 22. 23. Patients who seek a doctor's help typically do not know or understand the medical science behind their condition, which is why they go to a doctor in the first place. A patient with no medical or scientific background may not be able to understand what is going on with their body without their doctor explaining it to them. As a result, this can be a frightening and frustrating experience, filled with a sense of powerlessness and uncertainty for the patient. 22, 23, though in rare conditions, this pattern tends not to be followed, and due to lack of expertise patients are forced to learn about their conditions. 24, 155. An in-depth discussion of diagnosis, lab results, and treatment options and outcomes in layman's terms that the patient can understand can be reassuring and give the patient a sense of agency over their condition. Concurrently, this type of strong communication between a doctor and their patient can strengthen the physician-patient relationship as well as promote better treatment adherence and health outcomes. 22, 23. Coercion. Under certain conditions, healthcare workers are able to treat patients involuntarily, imprison them, or involuntarily administer drugs to alter the patient's ability to think. They may also engage in forms of informal coercion where information or access to social services can be used to control a patient. Deception. Lying in the doctor-patient relationship is common. 25, 164. Doctors provide minimal information to patients after medical errors. Doctors may lie to patients to displace culpability for poor outcomes and say they avoid giving patients information because it may confuse patients, cause pain, or undermine hope. They may lie to avoid uncomfortable conversation about disability or death, or to encourage patients to accept a particular treatment option. 25, 165. The experience of being lied to may undermine an individual's trust in others or themselves and reduce faith in one's church, community, or society and result in avoidant behavior to avoid being wounded. Patients may seek financial and legal retribution. 25, 166. Patients may lie to doctors for financial reasons such as to receive disability payments, for access to medication, or to avoid incarceration. Patients may lie out of embarrassment or shame. 25, 165. Palmera and Stern suggest that healthcare workers acknowledging the motivations of patients to lie to appear in a positive light to reduce deception by patients. 25, 167. Palmera and Stern offer different psychological framings and motivations for lying. From the perspective of attachment theory, lying may be used to avoid revealing information about an individual, to avoid intimacy and therefore the risk of rejection or shame, or to exaggerate to obtain protection or care. They also discuss the idea of protecting or maintaining an ego ideal. 25, 165. Generally, Palmera and Stern suggestion discussions about the amount of information and detail parties wish to discuss, viewing obtaining truth as an ongoing process to increase truthfulness in doctor-patient interactions. Palmera and Stern suggest that physicians acknowledge their lack of knowledge, and discuss the amount of detail they wish to discuss to avoid deception. 25, 167. Physician bias. Physicians have a tendency of overestimating their communication skills. 26, as well as the amount of information they provide their patients. 27. Extensive research conducted on 700 orthopedic surgeons and 807 patients, for instance, found that 75% of the surgeons perceived they satisfactorily communicated with their patients, whereas only 21% of the patients were actually satisfied with their communication. 28. Physicians also show a high likelihood of underestimating their patients' information needs and desires, especially for patients who were not college-educated or from economically disadvantaged backgrounds. 29, 30. There is pervasive evidence that patients' personal attributes such as age, sex, and socioeconomic status may influence how informative physicians are with their patients. 29, 30. Patients who are better educated and from upper or upper-middle-class positions generally receive higher quality and quantity of information from physicians than do those toward the other end of the social spectrum, although both sides have an equal desire for information. 30. Race, ethnicity and language has consistently proven to have a significant impact on how physicians perceive and interact with patients. 31. According to a study of 618 medical encounters between mainly Caucasian physicians and Caucasian and African American patients, physicians perceived African Americans to be less intelligent and educated, less likely to be interested in an active lifestyle, and more likely to have substance abuse problems than Caucasians. 32. A study of patients of color showed that having a white physician led to increased experience of microaggressions. 33. studies in Los Angeles emergency departments have found that Hispanic males and African Americans were less than half as likely to receive pain medication than Caucasians, despite physicians' estimates that patients were experiencing an equivalent level of pain. 31. Another study showed that ethnic minority groups of varying races reported lower quality healthcare experiences than non-Hispanic whites, specifically in treatment decision involvement and information received regarding medications. 34. Other studies show that physicians exhibited substantially less rapport-building and empathetic behavior with both Black and Hispanic patients than Caucasians, despite the absence of language barriers. 31. 18. 21. Medical mistrust. Mistrust of physicians or the healthcare system in general falls under the umbrella of medical mistrust. Medical mistrust negatively impacts the doctor-patient relationship, as a patient who has little faith in their physician is less likely to listen to their advice, follow their treatment plans, and feel comfortable disclosing information about themselves. Some forms of communication by the physician, such as self-disclosure and patient-centered communication, have been shown to decrease medical mistrust in patients. 35, 36. Medical mistrust has been shown to be greater for minority group patients and is associated with decreased compliance, which can contribute to poorer health outcomes. Research of breast cancer patients showed that African American women who received concerning mammogram results were less likely to discuss this with their doctor if they had greater medical mistrust. 37. Another study showed that women with higher physician mistrust waited longer to report symptoms to a doctor and receive a diagnosis of ovarian cancer. 38. Two studies showed that African American patients had more medical mistrust than white patients and were less likely to undergo a recommended surgery as a result. 35, 36. Benefiting or pleasing. A dilemma may arise in situations where determining the most efficient treatment, or encountering avoidance of treatment, creates a disagreement between the physician and the patient, for any number of reasons. In such cases, the physician needs strategies for presenting unfavorable treatment options or unwelcome information in a way that minimizes strain on the doctor-patient relationship while benefiting the patient's overall physical health and best interests. When the patient either cannot or will not do what the physician knows is the correct course of treatment, the patient becomes non-adherent. Adherence management coaching becomes necessary to provide positive reinforcement of unpleasant options. For example, according to a Scottish study, 39, patients want to be addressed by their first name more often than is currently the case. In this study, most of the patients either liked, 223, or did not mind, 175, being called by their first names. Only 77 individuals disliked being called by their first name, most of whom were aged over 65, 39. On the other hand, most patients do not want to call the doctor by his or her first name, 39. Some familiarity with the doctor generally makes it easier for patients to talk about intimate issues such as sexual subjects, but for some patients, a very high degree of familiarity may make the patient reluctant to reveal such intimate issues. 40. Transitional care. Transitions of patients between health care practitioners may decrease the quality of care in the time it takes to re-establish proper doctor-patient relationships. Generally, the doctor-patient relationship is facilitated by continuity of care in regard to attending personnel. Special strategies of integrated care may be required where multiple health care providers are involved, including horizontal integration, linking similar levels of care, e.g. multi-professional teams, and vertical integration, linking different levels of care, e.g. primary, secondary and tertiary care. 41. Turn-taking and conversational dominance. Researchers have studied the doctor-patient relationship using the theory of conversation analysis. 42. One of the key concepts in conversation analysis is turn-taking. The process of turn-taking between healthcare professionals and the patients has a profound impact on the relationship between them. In most scenarios, a doctor will walk into the room in which the patient is being held and will ask a variety of questions involving the patient's history, examination, and diagnosis. 43. These are often the foundation of the relationship between the doctor and the patient, as this interaction tends to be the first they have together. This can go a long way into impacting the future of the relationship throughout the patient's care. All speech acts between individuals seek to accomplish the same goal, sharing and exchanging information and meeting each participant's conversational goals. 43. Research carried out in medical scenarios analyzed 188 situations in which an interruption occurred between a physician and a patient. Of these 188 analyzed situations, research found that the doctor is much more likely, 67% of the time, 126 occasions, as compared to the patient, 33% of the time, 62 occasions. 43. This shows that physicians are practicing a form of conversational dominance in which they see themselves as far superior to the patient in terms of importance and knowledge and therefore dominate all aspects of the conversation. A question that comes to mind considering this is if interruptions hinder or improve the condition of the patient. Constant interruptions from the patient whilst the doctor is discussing treatment options and diagnoses can be detrimental or lead to less effective efforts in patient treatment. This is extremely important to take note of as it is something that can be addressed in quite a simple manner. This research conducted on doctor-patient interruptions also indicates that males are much more likely to interject out of turn in a conversation than women. 43. Men's social predisposition to interject becomes problematic when it negatively impacts a woman physician's messages to her patients who are men. She may not be able to finish her statements and the patient will not benefit from what she was about to say, and the physician herself may fall prey to the socially conventional man's interjection by letting it cut short her professional commentary. Conversely, men physicians need to encourage women patients to articulate their reactions and questions, since women interrupt in conversations statistically less often than men do. 43. A hurdle can arise from how the thinking process goes. A patient typically relates their story in chronological order, where symptoms, test results, consulting opinions, diagnoses and treatment are intertwined. A provider tends to design their approach in a step-by-step analytical manner, extracting as much details out of symptomatology, then past medical and social history, then tests, then coming to a suggested diagnosis and management plan. Addressing this upfront and at the onset of the visit and carving enough time for both can help avoid unnecessary interruptions on either part, improve provider-patient relation and constructively facilitate care. Other involved individuals. An example of where other people present in a doctor-patient encounter may influence their communication is one or more parents present at a minor's visit to a doctor. These may provide psychological support for the patient, but in some cases it may compromise the doctor-patient confidentiality and inhibit the patient from disclosing uncomfortable or intimate subjects. When visiting a health provider about sexual issues, having both partners of a couple present is often necessary, and is typically a good thing, but may also prevent the disclosure of certain subjects, and, according to one report, increases the stress level. 40. Having family around when dealing with difficult medical circumstances or treatments can also lead to complications. Family members, in addition to the patient needing treatment, may disagree on the treatment needing to be done. This can lead to tension and discomfort for the patient and the doctor, putting further strain on the relationship. Telehealth. With the extensive use of technology in healthcare, a new dynamic has risen in this relationship. Telehealth is the use of telecommunications and/or electronic information to support a patient. 44. This applies to clinical care, health-related education, and health administration. 45. An important fact about telehealth is that it increases the quality of the doctor-patient relationship by making health resources more easily available, affordable, and more convenient for both parties. Challenges with using telehealth are that it is harder to get reimbursements, to acquire cross-state licensure, to have common standards, maintain privacy, and have proper guiding principles. 44. The types of care that can be provided via telehealth include general health care, wellness visits, prescriptions for medicine, dermatology, eye exams, nutrition counseling, and mental health counseling. Just like with an in-person visit, it is important to prepare for a telehealth consultation beforehand and have good communication with the healthcare provider. 46. An interesting outcome of telehealth is that doctors have started to play a different role in the relationship. With patients having more access to information, medical knowledge, and their health data, doctors play the role of a translator between technical data and the patients. This has caused a shift in the way that the doctors see themselves concerning the doctor-patient relationship. Doctors who are engaged in telehealth see themselves as a guide to the patient and undertake the role of a guardian and information manager in the description, collection, and sharing of their patients' data. This is the new dynamic that has risen in this ancient relationship and one which will continue to evolve. 47. Bedside manner. Bedside manner redirects here. For other uses, see bedside manner. A medical doctor, with a nurse by his side, performs a blood test at a hospital in 1980. A good bedside manner is typically one that reassures and comforts the patient while remaining honest about a diagnosis. Vocal tones, body language, openness, presence, honesty, and concealment of attitude may all affect bedside manner. Poor bedside manner leaves the patient feeling unsatisfied, worried, frightened, or alone. Bedside manner becomes difficult when a healthcare professional must explain an unfavorable diagnosis to the patient, while keeping the patient from being alarmed. Dr. Rita Sharon launched the narrative medicine movement in 2001 with an article in the Journal of the American Medical Association. In the article she claimed that better understanding the patient's narrative could lead to better medical care. 48. Researchers and PhDs in a BMC medical education journal conducted a recent study that resulted in 5 key conclusions about the needs of patients from their healthcare providers. First, patients want their providers to provide reassurance. Second, patients feel anxious asking their providers questions. They want their providers to tell them it is okay to ask questions. Third, patients want to see their lab results and for the doctor to explain what they mean. Fourth, patients simply do not want to feel judged by their providers. And fifth, patients want to be participants in medical decision-making. They want providers to ask them what they want. 49. An example of how body language affects patient perception of care is that the time spent with the patient in the emergency department is perceived as longer if the doctor sits down during the encounter. 50. Patient behavior. Rude behavior by patients can have a negative effect on medical outcomes. A study showed that staff who received or witnessed rude behavior by patients' relatives had reduced ability to effectively carry out some of their simpler and more procedural tasks. This is important because if the medical staff are not performing sufficiently in what should be simple tasks, their ability to work effectively in critical conditions will also be impaired. This is consistent with research showing that rudeness by medical staff to one another decreases effectiveness. 51, 52. Examples in fiction. This section needs additional citations for verification. Please help improve this article by adding citations to reliable sources in this section. Unsourced material may be challenged and removed. July 2017, learn how and when to remove this template message. Dr. Gregory House, of the show House, has an acerbic, insensitive bedside manner. However, this is an extension of his normal personality. In Grey's Anatomy, Dr. Burke compliments Dr. George O'Malley's ability to care for Dr. Bailey's baby by saying it speaks to a good bedside manner. Doc Martin from the Doc Martin British TV series is a good example of a physician with a bad bedside manner. Dr. Lily Chow from the British TV series Casualty is another example of a foundation doctor with a poor bedside manner, whereas her colleague, Dr. Ethan Hardy, has a better one. In Lost, Hurley tells Jack Shephard that his bedside manner sucks. Later in the episode, Jack is told by his father to put more hope into his sayings, which he does when operating on his future wife. The comments continue in other episodes of the series with Benjamin Linus sarcastically telling Jack that his bedside manner leaves something to be desired after Jack gives him a harsh negative diagnosis. In Closer, Larry, the physician, tells Anna when they first meet that he is famed for his bedside manner. In Scrubs, J.D. is presented as an example of a physician with great bedside manner, while Elliot Reed is a physician with bad or non-existent bedside manner at first, until she evolves during her tenure at Sacred Heart. Dr. Cox is an interesting subversion, in that his manner is brash and undiplomatic while still inspiring patients to do their own best to aid in the healing process, akin to a drill sergeant. This show also comically remarked that the most time that a doctor needs to be in the presence of the patient before he finds out everything he needs to know is approximately 15 seconds. In Star Trek, Voyager, the doctor often compliments himself on the charming bedside manner he developed with the help of Kes. In M*A*S*S*H, Hawkeye Pierce, Trapper John McIntyre, B.J. Honeycutt, and Sherman Potter all possess a caring and humorous bedside manner meant to help patients cope with traumatic injuries. Charles Winchester initially possesses no real bedside manner, acting with detached professionalism, until the rigors of his job help him develop a sense of compassion for his patients. Frank Burns has a poor bedside manner, constantly minimizing the seriousness of his patients' injuries, accusing them of cowardice and goading them to return to the front lines. See also: Icon Medicine Portal, Aggression in Healthcare, Bullying in Medicine, Doctor-Patient Confidentiality, Duty of Candor, Medical Ethics, Medical Malpractice, Patient Abuse, Physician, Professional Boundaries. Patients' Welfare Association. The medical history, case history, or anamnesis, from Greek, new, ana, open, and munu sigma iota, nesis, memory, of a patient is a set of information the physicians collect over medical interviews. It involves the patient, and eventually people close to him, so to collect reliable/objective information for managing the medical diagnosis and proposing efficient medical treatments. The medically relevant complaints reported by the patient or others familiar with the patient are referred to as symptoms, in contrast with clinical signs, which are ascertained by direct examination on the part of medical personnel. Most health encounters will result in some form of history being taken. Medical histories vary in their depth and focus. For example, an ambulance paramedic would typically limit their history to important details, such as name, history of presenting complaint, allergies, etc. In contrast, a psychiatric history is frequently lengthy and in-depth, as many details about the patient's life are relevant to formulating a management plan for a psychiatric illness. The information obtained in this way, together with the physical examination, enables the physician and other health professionals to form a diagnosis and treatment plan. If a diagnosis cannot be made, a provisional diagnosis may be formulated, and other possibilities, the differential diagnoses, may be added, listed in order of likelihood by convention. The treatment plan may then include further investigations to clarify the diagnosis. The method by which doctors gather information about a patient's past and present medical condition in order to make informed clinical decisions is called the history and physical, aka the HMP. The history requires that a clinician be skilled in asking appropriate and relevant questions that can provide them with some insight as to what the patient may be experiencing. The standardized format for the history starts with the chief concern, why is the patient in the clinic or hospital, followed by the history of present illness, to characterize the nature of the symptoms or concerns, the past medical history, the past surgical history, the family history, the social history, their medications, their allergies, and a review of systems, where a comprehensive inquiry of symptoms potentially affecting the rest of the body is briefly performed to ensure nothing serious has been missed. 1. After all of the important history questions have been asked, a focused physical exam, meaning one that only involves what is relevant to the chief concern, is usually done. Based on the information obtained from the HMP, lab and imaging tests are ordered and medical or surgical treatment is administered as necessary. Process. Example. A practitioner typically asks questions to obtain the following information about the patient. Identification and demographics, name, age, height, weight. The chief complaint, CC, the major health problem or concern, and its time course, e.g. chest pain for past 4 hours. History of the present illness, HPI, details about the complaints, enumerated in the CC, also often called history of presenting complaint or HPC. Past medical history, PMH, including major illnesses, any previous surgery/operations, sometimes distinguished as past surgical history or PSH, any current ongoing illness, e.g. diabetes. Review of systems, ROS, systematic questioning about different organ systems. Family diseases, especially those relevant to the patient's chief complaint. Childhood diseases, this is very important in pediatrics. Social history, medicine, including living arrangements, occupation, marital status, number of children, drug use, including tobacco, alcohol, other recreational drug use, recent foreign travel, and exposure to environmental pathogens through recreational activities or pets. Regular and acute medications, including those prescribed by doctors, and others obtained over-the-counter or alternative medicine. Allergies, to medications, food, latex, and other environmental factors. Sexual history, obstetric/gynecological history, and so on, as appropriate. Conclusion and closure. History-taking may be comprehensive history-taking, a fixed and extensive set of questions are asked, as practiced only by healthcare students such as medical students, physician assistant students, or nurse practitioner students, or iterative hypothesis testing. Questions are limited and adapted to rule in or out likely diagnoses based on information already obtained, as practiced by busy clinicians. Computerized history-taking could be an integral part of clinical decision support systems. A follow-up procedure is initiated at the onset of the illness to record details of future progress and results after treatment or discharge. This is known as a catamnesis in medical terms. Review of systems. Main article, Review of systems. Whatever system a specific condition may seem restricted to, all the other systems are usually reviewed in a comprehensive history. The review of systems often includes all the main systems in the body that may provide an opportunity to mention symptoms or concerns that the individual may have failed to mention in the history. Healthcare professionals may structure the review of systems as follows. Cardiovascular system, chest pain, dyspnea, ankle swelling, palpitations, are the most important symptoms, and you can ask for a brief description for each of the positive symptoms. Respiratory system, cough, hemoptysis, epistaxis, wheezing, pain localized to the chest that might increase with inspiration or expiration. Gastrointestinal system, change in weight, flatulence and heartburn, dysphagia, odynophagia, hematemesis, melena, hematochezia, abdominal pain, vomiting, bowel habit. Genitourinary system, frequency in urination, pain with micturition, dysuria, urine color, any urethral discharge, altered bladder control like urgency in urination or incontinence, menstruation and sexual activity. Nervous system, headache, loss of consciousness, dizziness and vertigo, speech and related functions like reading and writing skills and memory. Cranial nerve symptoms, vision, amaurosis, diplopia, facial numbness, deafness, oropharyngeal dysphagia, limb motor or sensory symptoms and loss of coordination. Endocrine system, weight loss, polydipsia, polyuria, increased appetite, polyphagia, and irritability. Musculoskeletal system, any bone or joint pain accompanied by joint swelling or tenderness, aggravating and relieving factors for the pain and any positive family history for joint disease. Skin, any skin rash, recent change in cosmetics and the use of sunscreen creams when exposed to sun. Inhibiting factors. Factors that inhibit taking a proper medical history include a physical inability of the patient to communicate with the physician, such as unconsciousness and communication disorders. In such cases, it may be necessary to record such information that may be gained from other people who know the patient. In medical terms, this is known as a heteroanamnesis, or collateral history, in contrast to a self-reporting anamnesis. Medical history taking may also be impaired by various factors impeding a proper doctor-patient relationship, such as transitions to physicians that are unfamiliar to the patient. History taking of issues related to sexual or reproductive medicine may be inhibited by a reluctance of the patient to disclose intimate or uncomfortable information. Even if such an issue is on the patient's mind, he or she often doesn't start talking about such an issue without the physician initiating the subject by a specific question about sexual or reproductive health. 2. Some familiarity with the doctor generally makes it easier for patients to talk about intimate issues such as sexual subjects, but for some patients, a very high degree of familiarity may make the patient reluctant to reveal such intimate issues. 2. When visiting a health provider. About sexual issues, having both partners of a couple present is often necessary, and is typically a good thing, but may also prevent the disclosure of certain subjects, and, according to one report, increases the stress level. 2. Computer-assisted history taking. Computer-assisted history taking or computerized history taking systems have been available since the 1960s. 3. However, their use remains variable across healthcare delivery systems. 4. One advantage of using computerized systems as an auxiliary or even primary source of medically related information is that patients may be less susceptible to social desirability bias. For example, patients may be more likely to report that they have engaged in unhealthy lifestyle behaviors. Another advantage of using computerized systems is that they allow easy and high-fidelity portability to a patient's electronic medical record. Also, an advantage is that it saves money and paper. One disadvantage of many computerized medical history systems is that they cannot detect nonverbal communication, which may be useful for elucidating anxieties and treatment plans. Another disadvantage is that people may feel less comfortable communicating with a computer as opposed to a human. In a sexual history-taking setting in Australia using a computer-assisted self-interview, 51% of people were very comfortable with it, 35% were comfortable with it, and 14% were either uncomfortable or very uncomfortable with it. 5. The evidence for or against computer-assisted history-taking systems is sparse. As of 2011, there were no randomized control trials comparing computer-assisted versus traditional oral handwritten family history taking to identifying patients with an elevated risk of developing type 2 diabetes mellitus. 6. In 2021, a sub-study, 7, of a large prospective cohort trial, 8, showed that a majority, 70%, of patients with acute chest pain could, with computerized history taking, provide sufficient data for risk stratification with a well-established risk score, heart score. See also: genogram, medical record, medicine, physical examination, psychoanalysis. Freud uses the term anamnesis to describe neurotics' recounting of their symptoms. The terms medical record, health record and medical chart are used somewhat interchangeably to describe the systematic documentation of a single patient's medical history and care across time within one particular healthcare provider's jurisdiction. 1. A medical record includes a variety of types of notes entered over time by healthcare professionals, recording observations and administration of drugs and therapies, orders for the administration of drugs and therapies, test results, X-rays, reports, etc. The maintenance of complete and accurate medical records is a requirement of healthcare providers and is generally enforced as a licensing or certification prerequisite. The terms are used for the written, paper notes, physical, image films, and digital records that exist for each individual patient and for the body of information found therein. Medical records have traditionally been compiled and maintained by healthcare providers, but advances in online data storage have led to the development of personal health records, PHR, that are maintained by patients themselves, often on third-party websites. 2. This concept is supported by U.S. National Health Administration entities. 3. And by AHIMA, the American Health Information Management Association. 4. A medical record folder being pulled from the records. Because many consider the information in medical records to be sensitive private information covered by expectations of privacy, many ethical and legal issues are implicated in their maintenance, such as third-party access and appropriate storage and disposal. 5. Although the storage equipment for medical records generally is the property of the healthcare provider, the actual record is considered in most jurisdictions to be the property of the patient, who may obtain copies upon request. 6. Uses. The information contained in the medical record allows healthcare providers to determine the patient's medical history and provide informed care. The medical record serves as the central repository for planning patient care and documenting communication among patient and healthcare provider and professionals contributing to the patient's care. An increasing purpose of the medical record is to ensure documentation of compliance with institutional, professional, or governmental regulation. The traditional medical record for inpatient care can include admission notes, on-service notes, progress notes, SOAP notes, preoperative notes, operative notes, postoperative notes, procedure notes, delivery notes, postpartum notes, and discharge notes. Personal health records combine many of the above features with portability, thus allowing a patient to share medical records across providers and healthcare systems. 7. Electronic medical records could also be studied to quantify disease burdens, such as the number of deaths from antimicrobial resistance. 8. Or help identify causes of, factors of and contributors to diseases. 9, 10, especially when combined with genome-wide association studies. 11, 12, for such purposes, electronic medical records could potentially be made available in securely anonymized or pseudonymized. 13, forms to ensure patients' privacy is maintained. 14, 12, 15, 16. Contents. A patient's individual medical record identifies the patient and contains information regarding the patient's case history at a particular provider. The health record, as well as any electronically stored variant of the traditional paper files, contain proper identification of the patient. 17. Further information varies with the individual medical history of the patient. The contents are generally written with other healthcare professionals in mind. This can result in confusion and hurt feelings when patients read these notes. 18. For example, some abbreviations, such as for shortness of breath, are similar to the abbreviations for profanities, and taking time out to follow a surgical safety protocol might be misunderstood as a disciplinary technique for children. 18. Media applied. Traditionally, medical records were written on paper and maintained in folders often divided into sections for each type of note: progress note, order, test results, with new information added to each section chronologically. Active records are usually housed at the clinical site, but older records are often archived off-site. The advent of electronic medical records has not only changed the format of medical records but has increased accessibility of files. The use of an individual dossier-style medical record, where records are kept on each patient by name and illness type, originated at the Mayo Clinic out of a desire to simplify patient tracking and to allow for medical research. 19. Maintenance of medical records requires security measures to prevent from unauthorized access or tampering with the records. Medical history. The medical history is a longitudinal record of what has happened to the patient since birth. It chronicles diseases, major and minor illnesses, as well as growth landmarks. It gives the clinician a feel for what has happened before to the patient. As a result, it may often give clues to current disease state. It includes several subsets detailed below. Surgical history. The surgical history is a chronicle of surgery performed for the patient. It may have dates of operations, operative reports, and/or the detailed narrative of what the surgeon did. Obstetric history. The obstetric history lists prior pregnancies and their outcomes. It also includes any complications of these pregnancies. Medications and medical allergies. The medical record may contain a summary of the patient's current and previous medications as well as any medical allergies. Family history. The family history lists the health status of immediate family members as well as their causes of death, if known. 20. It may also list diseases common in the family or found only in one sex or the other. It may also include a pedigree chart. It is a valuable asset in predicting some outcomes for the patient. Social history. The social history is a chronicle of human interactions. It tells of the relationships of the patient, her careers and trainings, and religious training. It is helpful for the physician to know what sorts of community support the patient might expect during a major illness. It may explain the behavior of the patient in relation to illness or loss. It may also give clues as to the cause of an illness, e.g. occupational exposure to asbestos. Habits. Various habits which impact health, such as tobacco use, alcohol intake, exercise, and diet are chronicled, often as part of the social history. This section may also include more intimate details such as sexual habits and sexual orientation. Immunization history. The history of vaccination is included. Any blood tests proving immunity will also be included in this section. Growth chart and developmental history. For children and teenagers, charts documenting growth as it compares to other children of the same age is included, so that healthcare providers can follow the child's growth over time. Many diseases and social stresses can affect growth, and longitudinal charting can thus provide a clue to underlying illness. Additionally, a child's behavior, such as timing of talking, walking, etc., as it compares to other children of the same age, is documented within the medical record for much the same reasons as growth. Medical encounters. Within the medical record, individual medical encounters are marked by discrete summations of a patient's medical history by a physician, nurse practitioner, or physician assistant and can take several forms. Hospital admission documentation, i.e., when a patient requires hospitalization or consultation by a specialist, often take an exhaustive form, detailing the entirety of prior health and health care. Routine visits by a provider familiar to the patient, however, may take a shorter form such as the problem-oriented medical record, POMR, which includes a problem list of diagnoses or a SOAP method of documentation for each visit. Each encounter will generally contain the aspects below. Chief complaint. This is the main problem, traditionally called a complaint, that has brought the patient to see the doctor or other clinician. Information on the nature and duration of the problem will be explored. History of the present illness. A detailed exploration of the symptoms the patient is experiencing that have caused the patient to seek medical attention. Physical examination. The physical examination is the recording of observations of the patient. This includes the vital signs, muscle power, and examination of the different organ systems, especially ones that might directly be responsible for the symptoms the patient is experiencing. Assessment and plan. The assessment is a written summation of what are the most likely causes of the patient's current set of symptoms. The plan documents the expected course of action to address the symptoms, diagnosis, treatment, etc. Orders and prescriptions. Written orders by medical providers are included in the medical record. These detail the instructions given to other members of the healthcare team by the primary providers. Progress notes. When a patient is hospitalized, daily updates are entered into the medical record documenting clinical changes, new information, etc. These often take the form of a SOAP note and are entered by all members of the healthcare team, doctors, nurses, physical therapists, dietitians, clinical pharmacists, respiratory therapists, etc. They are kept in chronological order and document the sequence of events leading to the current state of health. Test results. The results of testing, such as blood tests, example, complete blood count, radiology examinations, example, X-rays, pathology, example, biopsy results, or specialized testing, example, pulmonary function testing, are included. Often, as in the case of X-rays, a written report of the findings is included in lieu of the actual film. Other information. Many other items are variably kept within the medical record. Digital images of the patient, flow sheets from operations/intensive care units, informed consent forms, EKG tracings, outputs from medical devices, such as pacemakers, chemotherapy protocols, and numerous other important pieces of information form part of the record depending on the patient and his or her set of illnesses/treatments. Administrative issues. A ward clerk in the Menn Hospital, Colorado. Medical records are legal documents that can be used as evidence via a subpoena dutes tecum, 21, and are thus subject to the laws of the country/state in which they are produced. As such, there is great variability in rules governing production, ownership, accessibility, and destruction. There is some controversy regarding proof verifying the facts, or absence of facts in the record, apart from the medical record itself, citation needed. In 2009, Congress authorized and funded legislation known as the Health Information Technology for Economic and Clinical Health Act, 22, to stimulate the conversion of paper medical records into electronic charts. While many hospitals and doctors' offices have since done this successfully, electronic health vendors' proprietary systems are sometimes incompatible. 23. Demographics. Demographics include patient information that is not medical in nature. It is often information to locate the patient, including identifying numbers, addresses, and contact numbers. It may contain information about race and religion as well as workplace and type of occupation. It also contains information regarding the patient's health insurance. It is common to also find emergency contact information located in this section of the medical chart. Production. In the United States, written records must be marked with the date and time inscribed with indelible pens without use of corrective paper. Errors in the record should be struck out with a single line, so that the initial entry remains legible, and initialed by the author. 21. Orders and notes must be signed by the author. Electronic versions require an electronic signature. Ownership of patient's record. Ownership and keeping of patient's records varies from country to country. U.S. law and customs. In the United States, the data contained within the medical record belongs to the patient, whereas the physical form the data takes belongs to the entity responsible for maintaining the record. 24. Per the Health Insurance Portability and Accountability Act, 25, patients have the right to ensure that the information contained in their record is accurate, and can petition their health care provider to amend factually incorrect information in their records. 21, 26. There is no consensus regarding medical record ownership in the United States. Factors complicating questions of ownership include the form and source of the information, custody of the information, contract rights, and variation in state law. 27. There is no federal law regarding ownership of medical records. HIPAA gives patients the right to access and amend their own records, but it has no language regarding ownership of the records. 28. 28 states and Washington, D.C., have no laws that define ownership of medical records. 21 states have laws stating that the providers are the owners of the records. Only one state, New Hampshire, has a law ascribing ownership of medical records to the patient. 29. Canadian law and customs. Under Canadian federal law, the patient owns the information contained in a medical record, but the healthcare provider owns the records themselves. 30. The same is true for both nursing home and dental records. In cases where the provider is an employee of a clinic or hospital, it is the employer that has ownership of the records. By law, all providers must keep medical records for a period of 15 years beyond the last entry. 31. The precedent for the law is the 1992 Canadian Supreme Court ruling in McInerney v. MacDonald. In that ruling, an appeal by a physician, Dr. Elizabeth McInerney, challenging a patient's access to their own medical record was denied. The patient, Margaret MacDonald, won a court order granting her full access to her own medical record. 32. The case was complicated by the fact that the records were in electronic form and contained information supplied by other providers. McInerney maintained that she didn't have the right to release records she herself did not author. The courts ruled otherwise. Legislation followed, codifying into law the principles of the ruling. It is that legislation which deems providers the owner of medical records, but requires that access to the records be granted to the patient themselves. 33. UK Law and Customs. In the United Kingdom, ownership of the NHS's medical records has in the past generally been described as belonging to the Secretary of State for Health. 34, and this is taken by some to mean copyright also belongs to the authorities. 35. German Law and Customs. In Germany, a relatively new law, 36, which has been established in 2013, strengthens the rights of patients. It states, amongst other things, the statutory duty of medical personnel to document the treatment of the patient in either hard copy or within the electronic patient record, EPR. This documentation must happen in a timely manner and encompass each and every form of treatment the patient receives, as well as other necessary information, such as the patient's case history, diagnoses, findings, treatment results, therapies and their effects, surgical interventions and their effects, as well as informed consents. The information must include virtually everything that is of functional importance for the actual, but also for future treatment. This documentation must also include the medical report and must be archived by the attending physician for at least 10 years. The law clearly states that these records are not only memory aids for the physicians, but also should be kept for the patient and must be presented on request. In addition, an electronic health insurance card was issued in January 2014 which is applicable in Germany, Elektronische Gesundheitskarte or EGK, but also in the other member states of the European Union, European Health Insurance Card. It contains data such as the name of the health insurance company, the validity period of the card, and personal information about the patient, name, date of birth, sex, address, health insurance number, as well as information about the patient's insurance status and additional charges. Furthermore, it can contain medical data if agreed to by the patient. This data can include information concerning emergency care, prescriptions, an electronic medical record, and electronic physician's letters. However, due to the limited storage space, 32 KB, some information is deposited on servers. Accessibility. United States. In the United States, the most basic rules governing access to a medical record dictate that only the patient and the healthcare providers directly involved in delivering care have the right to view the record. The patient, however, may grant consent for any person or entity to evaluate the record. The full rules regarding access and security for medical records are set forth under the guidelines of the Health Insurance Portability and Accountability Act, HIPAA. The rules become more complicated in special situations. A 2018 study found discrepancies in how major hospitals handle record requests, with forms displaying limited information relative to phone conversations. 37. Capacity. When a patient does not have capacity, is not legally able to make decisions regarding his or her own care, a legal guardian is designated either through next of kin or by action of a court of law if no kin exists. Legal guardians have the ability to access the medical record in order to make medical decisions on the patient's behalf. Those without capacity include the comatose, minors, unless emancipated, and patients with incapacitating psychiatric illness or intoxication. Medical emergency. In the event of a medical emergency involving a non-communicative patient, consent to access medical records is assumed unless written documentation has been previously drafted, such as an advance directive. Research, auditing, and evaluation. Individuals involved in medical research, financial or management audits, or program evaluation have access to the medical record. They are not allowed access to any identifying information, however. Risk of death or harm. Information within the record can be shared with authorities without permission when failure to do so would result in death or harm either to the patient or to others. Information cannot be used, however, to initiate or substantiate a charge unless the previous criteria are met, i.e., information from illicit drug testing cannot be used to bring charges of possession against a patient. This rule was established in the United States Supreme Court case Jaffe v. Redmond, 1. Canada. In the 1992 Canadian Supreme Court ruling in McInerney v. MacDonald gave patients the right to copy and examine all information in their medical records, while the records themselves remained the property of the healthcare provider. 32. The 2004 Personal Health Information Protection Act, FIPA, contains regulatory guidelines to protect the confidentiality of patient information for healthcare organizations acting as stewards of their medical records. 38. despite legal precedent for access. Nationwide, there is still some variance in laws depending on the province. There is also some confusion among providers as to the scope of the patient information they have to give access to, but the language in the Supreme Court ruling gives patient access rights to their entire record. 39. United Kingdom. In the United Kingdom, the Data Protection Acts and later the Freedom of Information Act 2000 gave patients or their representatives the right to a copy of their record, except where information breaches confidentiality, example, information from another family member, or where a patient has asked for information not to be disclosed to third parties, or would be harmful to the patient's well-being, example, some psychiatric assessments. Also, the legislation gives patients the right to check for any errors in their record and insist that amendments be made if required. Destruction. In general, entities in possession of medical records are required to maintain those records for a given period. In the United Kingdom, medical records are required for the lifetime of a patient and legally for as long as that complaint action can be brought. Generally in the UK, any recorded information should be kept legally for 7 years, but for medical records additional time must be allowed for any child to reach the age of responsibility, 20 years. Medical records are required many years after a patient's death to investigate illnesses within a community, example, industrial or environmental disease, or even deaths at the hands of doctors committing murders, as in the Harold Shipman case. 40. Abuses. The outsourcing of medical record transcription and storage has the potential to violate patient-physician confidentiality by possibly allowing unaccountable persons access to patient data. With the increase of clinical notes being shared as a result of the 21st Century Cures Act, the increase in sensitive terms used in the records of all patients, including minors, are increasingly shared amongst care teams, making privacy more complicated. 41. Intersex people have historically had their medical records intentionally falsified/concealed to hide birth sex and intersex medical procedures. Christian Walling became the first intersex person in Europe to successfully sue for medical malpractice. 42. Falsification of a medical record by a medical professional is a felony in most United States jurisdictions. Governments have often refused to disclose medical records of military personnel who have been used as experimental subjects. Data breaches. Given the series of medical data breaches and the lack of public trust, some countries have enacted laws requiring safeguards to be put in place to protect the security and confidentiality of medical information as it is shared electronically, and to give patients some important rights to monitor their medical records and receive notification for loss and unauthorized acquisition of health information. The United States and the EU have imposed mandatory medical data breach notifications. 43. Patients' medical information can be shared by a number of people both within the healthcare industry and beyond. The Health Insurance Portability and Accessibility Act, HIPAA, is a United States federal law pertaining to medical privacy that went into effect in 2003. This law established standards for patient privacy in all 50 states, including the right of patients to access to their own records. HIPAA provides some protection, but does not resolve the issues involving medical records privacy. 44. Medical and health care providers experienced 767 security breaches, resulting in the compromised confidential health information of 23,625,933 patients during the period of 2006-2012. 45. The Federal Health Insurance Portability and Accessibility Act, HIPAA, addresses the issue of privacy by providing medical information handling guidelines. 46. Not only is it bound by the code of ethics of its profession, in the case of doctors and nurses, but also by the legislation on data protection and criminal law. Professional secrecy applies to practitioners, psychologists, nursing, physiotherapists, occupational therapists, nursing assistants, chiropodists, and administrative personnel, as well as auxiliary hospital staff. The maintenance of the confidentiality and privacy of patients implies first of all in the medical history, which must be adequately guarded, remaining accessible only to the authorized personnel. However, the precepts of privacy must be observed in all fields of hospital life: privacy at the time of the conduct of the anamnesis and physical exploration, the privacy at the time of the information to the relatives, the conversations between healthcare providers in the corridors, maintenance of adequate patient data collection in hospital nursing controls, planks, slates, telephone conversations, open intercoms, etc. See also: Icon Medicine Portal, Bioethics, Electronic Health Record. Hospital Information System, Medical History, Medical Law, Open Notes, Patient Record Access, Right to Know, Physical Examination, Physician-Patient Privilege, Labor Inspection, Midwife, Nursing, Pharmaceutical. In a physical examination, medical examination, or clinical examination, a medical practitioner examines a patient for any possible medical signs or symptoms of a medical condition. It generally consists of a series of questions about the patient's medical history followed by an examination based on the reported symptoms. Together, the medical history and the physical examination help to determine a diagnosis and devise the treatment plan. These data then become part of the medical record. Citation needed. Types. A doctor using a stethoscope to listen to a 15-month-old's abdomen. Routine. The routine physical, also known as general medical examination, periodic health evaluation, annual physical, comprehensive medical exam, general health check, preventive health examination, medical checkup, or simply medical, is a physical examination performed on an asymptomatic patient for medical screening purposes. These are normally performed by a pediatrician, family practice physician, a physical therapist, physician assistant, a certified nurse practitioner or other primary care provider. This routine physical exam usually includes the HINT evaluation. Nursing professionals such as registered nurse, licensed practical nurses can develop a baseline assessment to identify normal versus abnormal findings. 1. These are reported to the primary care provider. If necessary, the patient may be sent to a medical specialist for further, more detailed examinations. The term is generally not meant to include visits for the purpose of newborn checks, pap smears for cervical cancer, or regular visits for people with certain chronic medical disorders, for example, diabetes. 2. The general medical examination generally involves a medical history, a brief or complete physical examination and sometimes laboratory tests. Some more advanced tests include ultrasound and mammography. If done for a group of people, the routine physical is a form of screening, as the aim of the examination is to detect early signs of diseases to prevent them. 3. Evidence. Although annual medical examinations are a routine practice in several countries, examinations performed on an asymptomatic patient are poorly supported by scientific evidence in the majority of the population. A Cochrane collaboration meta-study found that routine annual physicals did not measurably reduce the risk of illness or death, and conversely, could lead to overdiagnosis and overtreatment. However, this article does not conclude that being in regular communication with a doctor is not important, simply that an actual physical examination may not be necessary. 4. Some notable general health organizations recommend against annual examinations, and propose a frequency adapted to age and previous examination results. Risk factors. 5, 6, 7. The Specialist American Cancer Society recommends a cancer-related health checkup annually in men and women older than 40, and every 3 years for those older than 20. 8. A systematic review of studies until September 2006 concluded that the examination does result in better delivery of some other screening interventions, such as pap smears, cholesterol screening, and fecal occult blood tests, and less patient worry. 2. Evidence supports several of these individual screening interventions. 9, 10, 11. The effects of annual checkups on overall costs, patient disability and mortality, disease detection, and intermediate endpoints such as blood pressure or cholesterol are inconclusive. 2. A recent study found that the examination is associated with increased participation in cancer screening. 12. Some employers, require a mandatory health checkup before hiring a candidate, even though it is now well known that some of the components of the prophylactic annual visit may actually cause harm. For example, lab tests and exams that are performed on healthy patients, as opposed to people with symptoms or known illnesses, are statistically more likely to be false positives, that is, when test results suggest a problem that does not exist. 13. Disadvantages cited include the time and money that could be saved by targeted screening, health economics argument, 14. Increased anxiety over health risks, medicalization, overdiagnosis, wrong diagnosis, for example athletic heart syndrome, misdiagnosed as hypertrophic cardiomyopathy, and harm or even death, resulting from unnecessary testing to detect or confirm, often non-existent, medical problems or while performing routine procedures as a follow-up after screening. 15, 16, 17. The lack of good evidence contrasts with population surveys showing that the general public is fond of these examinations, especially when they are free of charge. 18. Despite guidelines recommending against routine annual examinations, many family physicians perform them. 19. A fee-for-service healthcare system has been suggested to promote this practice. 20. An alternative would be to tailor the screening interval to the age, sex, medical conditions and risk factors of each patient. 6. 21, 22. This means choosing between a wide variety of tests. 23. Prevalence. The routine physical is commonly performed in the United States and Japan, whereas the practice varies among Southeast Asia and mainland European countries. In Japan it is required by law for regular working employees to check once a year, with a much more thorough battery of tests than other countries. Citation needed. History. The roots of the periodic medical examination are not entirely clear. They seem to have been advocated since the 1920s. 24. Some authors point to pleads from the 19th and early 20th century for the early detection of diseases like tuberculosis, and periodic school health examinations. 25. The advent of medical insurance and related commercial influences seems to have promoted the examination, whereas this practice has been subject to controversy in the age of evidence-based medicine. 20, 25, 26, 27, 28. Several studies have been performed before current evidence-based recommendation for screening were formulated, limiting the applicability of these studies to current-day practice. 2, 29, 30. Comprehensive. Comprehensive physical exams, also known as executive physicals, typically include laboratory tests, chest X-rays, pulmonary function testing, audiograms, full body CAT scanning, EKGs, heart stress tests, vascular age tests, urinalysis, and mammograms or prostate exams depending on gender. 31. Pre-employment. Pre-employment examinations are screening tests which judge the suitability of a worker for hire based on the results of their physical examination. 32. This is also called pre-employment medical clearance. Some employers believe that by only hiring workers whose physical examination results pass certain exclusionary criteria, their employees collectively will have fewer absences due to sickness, fewer workplace injuries, and less occupational disease. 32. A small amount of low-quality evidence in medical research supports this idea. 32. Furthermore, the cost of staff health insurance will be lower. However, certain exams or tests that are requested by employers, such as a baseline low back X-ray, should not be performed, according to the American College of Occupational and Environmental Medicine. Reasons for this include the legality and medical necessity of the test as well as the inability of such testing to predict future problems, the radiation exposure to the worker, and the cost of the exam. 33. Insurance. A physical examination may be provided under health insurance cover, required of new insurance customers. This is a part of insurance medicine. In the United States, physicals are also marketed to patients as a one-stop health review, avoiding the inconvenience of attending multiple appointments with different healthcare providers. 34, 35. Uses. Medical doctor examines a young girl, Guinea-Bissau, 1974. Diagnosis. Physical examinations are performed in most healthcare encounters. For example, a physical examination is performed when a patient visits complaining of flu-like symptoms. These diagnostic examinations usually focus on the patient's chief complaint. Citation needed. Screening. General health checks, including physical examinations performed when the patient reported no health concerns, often include medical screening for common conditions, such as high blood pressure. A Cochrane review found that general health checks did not reduce the risk of death from cancer, heart disease, or any other cause, and could not be proved to affect the patient's likelihood of being admitted to the hospital, becoming disabled, missing work, or needing additional office visits. The study found no effect on the risk of illness, but did find evidence suggesting that patients subject to routine physicals were diagnosed with hypertension and other chronic conditions at a higher rate than those who were not. Its authors noted that studies often failed to consider or report possible harmful outcomes, such as unwarranted anxiety or unnecessary follow-up procedures, and concluded that routine health checks were unlikely to be beneficial in regards to lowering cardiovascular and cancer morbidity and mortality. 4. Doctor-patient relations. Main article, Doctor-patient relationship. Physical examination has been described as a ritual that plays a significant role in the doctor-patient relationship that will provide benefits in other medical encounters. 36. When a physical exam is expected by the patient but is not performed by the provider, patients may express concern for the lack of depth of investigation into their illness, the validity of treatment plans and exclusions, and the doctor-patient relationship. 37. Format and interpretation. Auscultation of a man in Vietnam. A physical examination may include checking vital signs, including temperature examination, blood pressure, pulse, and respiratory rate. The healthcare provider uses the senses of sight, hearing, touch, and sometimes smell, example, in infection, uremia, diabetic ketoacidosis. Taste has been made redundant by the availability of modern lab tests. For actions are taught as the basis of physical examination: inspection, palpation, feel, percussion, tap to determine resonance characteristics, and auscultation, listen. 38. Scope. Although providers have varying approaches as to the sequence of body parts, a systematic examination generally starts at the head and finishes at the extremities and includes evaluation of general patient appearance and specific organ systems. After the main organ systems have been investigated by inspection, palpation, percussion, and auscultation, specific tests may follow, such as a neurological investigation, orthopedic examination, or specific tests when a particular disease is suspected, e.g. eliciting Trousseau's sign in hypocalcemia. Citation needed. While the format of examination as listed below is largely as taught and expected of students, a specialist will focus on their particular field and the nature of the problem described by the patient. Hence, a cardiologist will not in routine practice undertake neurological parts of the examination other than noting that the patient is able to use all four limbs on entering the consultation room and during the consultation become aware of their hearing, eyesight, and speech. Likewise, an orthopedic surgeon will examine the affected joint, but may only briefly check the heart sounds and chest to ensure that there is not likely to be any contraindication to surgery raised by the anesthetist. A primary care physician will also generally examine the male genitals but may leave the examination of the female genitalia to a gynecologist. With the clues obtained during the history and physical examination, the healthcare provider can now formulate a differential diagnosis, a list of potential causes of the symptoms. Specific diagnostic tests, or occasionally empirical therapy, generally confirm the cause, or shed light on other, previously overlooked, causes. The physical exam is then recorded in the medical record in a standard layout which facilitates billing and other providers later reading the notes. A doctor examining a pediatric patient in hospital. While elective physical exams have become more elaborate, in routine use physical exams have become less complete. This has led to editorials in medical journals about the importance of an adequate physical examination. 39, 40. Physicians at Stanford University Medical School have introduced a set of 25 key physical examination skills that were felt to be useful. 41. Recording. Section sample text comments. General patient in NAD. vs. WNL may be split on two lines. WNL equals within normal limits. Hint, NC/at. Perla, EOMI. No cervical LAD, no thyromegaly, no brute, no pallor. Fundus WNL, oropharynx WNL, tympanic membrane WNL, neck supple neck is sometimes split out from head. Good dentition may be noted. RESP or chest non-tender, CTA Bilet chest expansion test, normal breathing with little effort, absence of wheezing, rhonchi and crackles. More detailed examinations can include rals, rhonchi, wheezing, no or slash W, and rubs. Other phrases may include no cyanosis or clubbing, if section is labeled RESP and not chest, fremitus WNL, and no dullness to percussion. CV or heart plus S1, plus S2, RRR, no M/or/G if CV is used instead of heart. Peripheral pulses are sometimes included in this section, otherwise, they may be in the extremities section. ABD soft, non-tender, non-distended, absence of pain, no hepatosplenomegaly. NBS if lower back pain is involved, then the back may become a primary section. Costovertebral angle tenderness may be included in the abdominal section if there is no back section. More detailed examinations may report plus psoas sign, plus Rovsing sign, plus obturator sign. If tenderness was present, it might be reported as direct and rebound RLQ tenderness. NBS stands for normal bowel sounds. Alternatives might include hypoactive BS or hyperactive BS. EXT no clubbing, cyanosis, edema. Checking the fingers for clubbing and cyanosis is sometimes considered part of the pulmonary exam, because it closely involves oxygenation. Examinations of the knee may involve the McMurray test, Lockman test, and Dror test. Neuro A and OX3, CN2 to 12 grossly intact, sensation intact in all four extremities, dull and sharp, DTR2 plus Bilet, Romberg negative, cerebellar reflexes WNL, normal gait sensation may be expanded to include dull, sharp, vibration, temperature, and position sense. A mental status exam may be reported at the beginning of the neurologic exam or under a distinct psych section. Depending upon the chief complaint, additional sections may be included. For example, hearing may be evaluated with a specific Weber test and Rinne test, or it may be more briefly addressed in a cranial nerve exam. To give another example, a neurological-related complaint might be evaluated with a specific test, such as the Romberg maneuver. History. The medical history and physical examination were supremely important to diagnosis before advanced health technology was developed, and even today, despite advances in medical imaging and molecular medical tests, the history and physical remain indispensable steps in evaluating any patient. Before the 19th century, the history and physical examination were nearly the only diagnostic tools the physician had, which explains why tactile skill and ingenious appreciation in the exam were so highly valued in the definition of what made for a good physician. Even as late as 1890, the world had no radiography or fluoroscopy, only early and limited forms of electrophysiologic testing, and no molecular biology as we know it today. Ever since this peak of the importance of the physical examination, reviewers have warned that clinical practice and medical education need to remain vigilant in appreciating the continuing need for physical examination and effectively teaching the skills to perform it. This call is ongoing, as the 21st century literature shows. 42-43. Society and culture. Icon. This section needs expansion. You can help by adding to it. August 2019. People may request modesty in medical settings when the healthcare provider examines them. In many Western societies, a physical exam is required to participate in extracurricular sporting activities. During the physical examination, the doctor will examine the genitals, including the penis and testicles. The doctor may ask the teenager to cough while examining the scrotum. Although this can be embarrassing for an adolescent male, it is necessary to help evaluate the presence of inguinal hernias or tumors. 44. See also. Wikimedia Commons has media related to physical examinations. Heart sounds, noise generated by the beating heart. Medical record, medical term. Mental status examination, way of observing and describing a patient's current state of mind. A medical device is any device intended to be used for medical purposes. Significant potential for hazards are inherent when using a device for medical purposes, and thus medical devices must be proved safe and effective with reasonable assurance before regulating governments allow marketing of the device in their country. As a general rule, as the associated risk of the device increases, the amount of testing required to establish safety and efficacy also increases. Further, as associated risk increases, the potential benefit to the patient must also increase. Discovery of what would be considered a medical device by modern standards dates as far back as c. 700 BC in Baluchistan, where Neolithic dentists used flint-tipped drills and bowstrings. 1. Study of archaeology and Roman medical literature also indicate that many types of medical devices were in widespread use during the time of ancient Rome. 2. In the United States, it was not until the Federal Food, Drug, and Cosmetic Act, FDNC Act, in 1938 that medical devices were regulated. Later in 1976, the Medical Device Amendments to the FDNC Act established medical device regulation and oversight as we know it today in the United States. 3. Medical device regulation in Europe as we know it today came into effect in 1993 by what is collectively known as the Medical Device Directive, MDD. On May 26, 2017, the Medical Device Regulation, MDR, replaced the MDD. Medical devices vary in both their intended use and indications for use. Examples range from simple, low-risk devices such as tongue depressors, medical thermometers, disposable gloves, and bedpans to complex, high-risk devices that are implanted and sustain life. One example of high-risk devices are those with embedded software such as pacemakers, and which assist in the conduct of medical testing, implants, and prostheses. The design of medical devices constitutes a major segment of the field of biomedical engineering. The global medical device market was estimated to be between $220 and $250 billion in 2013. The United States controls 40% of the global market, followed by Europe, 25%, Japan, 15%, and the rest of the world, 20%. Although collectively Europe has a larger share, Japan has the second largest country market share. The largest market shares in Europe, in order of market share size, belong to Germany, Italy, France, and the United Kingdom. The rest of the world comprises regions like, in no particular order, Australia, Canada, China, India, and Iran. This article discusses what constitutes a medical device in these different regions, and throughout the article these regions will be discussed in order of their global market share. Definition: medical devices were used for surgery in ancient Rome. A global definition for medical device is difficult to establish because there are numerous regulatory bodies worldwide overseeing the marketing of medical devices. Although these bodies often collaborate and discuss the definition in general, there are subtle differences in wording that prevent a global harmonization of the definition of a medical device, thus the appropriate definition of a medical device depends on the region. Often a portion of the definition of a medical device is intended to differentiate between medical devices and drugs, as the regulatory requirements of the two are different. Definitions also often recognize in vitro diagnostics as a subclass of medical devices and establish accessories as medical devices. Definitions by region. United States, Food and Drug Administration. Section 201(h) of the Federal Food, Drug and Cosmetic (FDNC) Act, 5, defines a device as an instrument, apparatus, implement, machine, contrivance, implant, in vitro reagent, or other similar or related article, including a component part, or accessory which is recognized in the official national formulary, or the United States Pharmacopoeia, or any supplement to them. Intended for use in the diagnosis of disease or other conditions, or in the cure, mitigation, treatment, or prevention of disease, in man or other animals, or intended to affect the structure or any function of the body of man or other animals, and which does not achieve its primary intended purposes through chemical action within or on the body of man or other animals, and which is not dependent upon being metabolized for the achievement of its primary intended purposes. The term device does not include software functions excluded pursuant to Section 520(0). European Union. According to Article 1 of Council Directive 93/42/EC, 6, medical device means any instrument, apparatus, appliance, software, material or other article, whether used alone or in combination, including the software intended by its manufacturer to be used specifically for diagnostic and/or therapeutic purposes and necessary for its proper application, intended by the manufacturer to be used for human beings for the purpose of diagnosis, prevention, monitoring, treatment or alleviation of disease. Diagnosis, monitoring, treatment, alleviation of or compensation for an injury or handicap. Investigation, replacement or modification of the anatomy or of a physiological process. Control of conception, and which does not achieve its principal intended action in or on the human body by pharmacological, immunological or metabolic means, but which may be assisted in its function by such means. EU legal framework. Based on the new approach, rules that relate to safety and performance of medical devices were harmonized in the EU in the 1990s. The new approach, defined in a European Council resolution of May 1985, 7, represents an innovative way of technical harmonization. It aims to remove technical barriers to trade and dispel the consequent uncertainty for economic operators, to facilitate free movement of goods inside the EU, citation needed. The previous core legal framework consisted of 3 directives. Frowny-face citation needed. Directive 90/385/EEC regarding active implantable medical devices. Directive 93/42/EEC regarding medical devices. Directive 98/79/EC regarding in vitro diagnostic medical devices. Until 2022, the In Vitro Diagnosis Regulation, IVDR, will replace the EU's current directive on in vitro diagnostic, 98/79/EC. They aim at ensuring a high level of protection of human health and safety and the good functioning of the single market. These 3 main directives have been supplemented over time by several modifying and implementing directives, including the last technical revision brought about by Directive 2007/47/EC. 8. The government of each member state must appoint a competent authority responsible for medical devices. 9. The competent authority, CA, is a body with authority to act on behalf of the member state to ensure that member state government transposes requirements of medical device directives into national law and applies them. The CA reports to the Minister of Health in the member state. The CA in one member state has no jurisdiction in any other member state, but exchanges information and tries to reach common positions. In the UK, for example, the Medicines and Healthcare Products Regulatory Agency, MHRA, acted as a CA. In Italy it is the Ministero Salute, Ministry of Health. Medical devices must not be mistaken with medicinal products. In the EU, all medical devices must be identified with the CE mark. The conformity of a medium or high-risk medical device with relevant regulations is also assessed by an external entity, the notified body, before it can be placed on the market. In September 2012, the European Commission proposed new legislation aimed at enhancing safety, traceability, and transparency. 10. The regulation was adopted in 2017. The future core legal framework consists of 2 regulations, replacing the previous 3 directives. The Medical Devices Regulation, MDR, EU, 2017/745. The In Vitro Diagnostic Medical Devices Regulation, IVDR, EU, 2017/746. Japan. Article 2, Paragraph 4, of the Pharmaceutical Affairs Law, PAL, 11, defines medical devices as instruments and apparatus intended for use in diagnosis, cure or prevention of diseases in humans or other animals, intended to affect the structure or functions of the body of man or other animals. Rest of the world. Canada. Bags of medical supplies and defibrillators at the York Region EMS Logistics Headquarters in Ontario, Canada. The term medical device, as defined in the Food and Drugs Act, is any article, instrument, apparatus, or contrivance, including any component, part or accessory thereof, manufactured, sold or represented for use in the diagnosis, treatment, mitigation or prevention of a disease, disorder or abnormal physical state, or its symptoms, in a human being, the restoration, correction or modification of a body function or the body structure of a human being, the diagnosis of pregnancy in a human being, or the care of a human being during pregnancy and at and after the birth of a child, including the care of the child. It also includes a contraceptive device but does not include a drug. 12. The term covers a wide range of health or medical instruments used in the treatment, mitigation, diagnosis or prevention of a disease or abnormal physical condition. Health Canada reviews medical devices to assess their safety, effectiveness, and quality before authorizing their sale in Canada. 13. According to the Act, medical device does not include any device that is intended for use in relation to animals. 14. India. This section does not cite any sources. Please help improve this section by adding citations to reliable sources. Unsourced material may be challenged and removed. June 2022, learn how and when to remove this template message. There is no specific definition of the term medical devices in Indian law. However, certain medical devices are notified as drugs under the Drugs and Cosmetics Act. Section 3(b)(4), relating to definition of drugs holds that devices intended for internal or external use in the diagnosis, treatment, mitigation or prevention of disease or disorder in human beings or animals are also drugs. 15. As of April 2022, 14 classes of devices are classified as drugs. Regulation and oversight. Risk classification. A stethoscope, US FDA Product Code BZS, a popular Class 1 medical device as determined by the US FDA, ubiquitous in hospitals. The regulatory authorities recognize different classes of medical devices based on their potential for harm if misused, design complexity, and their use characteristics. Each country or region defines these categories in different ways. The authorities also recognize that some devices are provided in combination with drugs, and regulation of these combination products takes this factor into consideration. Classifying medical devices based on their risk is essential for maintaining patient and staff safety while simultaneously facilitating the marketing of medical products. By establishing different risk classifications, lower risk devices, for example, a stethoscope or tongue depressor, are not required to undergo the same level of testing that higher-risk devices such as artificial pacemakers undergo. Establishing a hierarchy of risk classification allows regulatory bodies to provide flexibility when reviewing medical devices. Citation needed. Classification by region. United States. Main article, Medical Device Manufacturing. Further information, Federal Food, Drug, and Cosmetic Act Medical Devices. This section duplicates the scope of other articles, specifically medical device manufacturing. Please discuss this issue on the talk page and edit it to conform with Wikipedia's manual of style by replacing the section with a link and a summary of the repeated material or by spinning off the repeated text into an article in its own right. March 2019. Under the Food, Drug, and Cosmetic Act, the U.S. Food and Drug Administration recognizes 3 classes of medical devices, based on the level of control necessary to assure safety and effectiveness. 16. Class 1. Class 2. Class 3. Device Class Risk FDA Regulatory Control Examples. Class 1 Low Risk General Controls Tongue, electric toothbrush, bandages, hospital beds. Class 2 Medium Risk General Controls plus Pre-Market Notification, 510K, catheters, contact lenses, pregnancy test kits. Class 3 High Risk General Controls plus Special Controls, 510K, plus Pre-Market Approval, PMA, pacemakers, defibrillators, implanted prosthetics, breast implants. The classification procedures are described in the Code of Federal Regulations, Title 21, Part 860, usually known as 21 CFR 860.17. Class 1 devices are subject to the least regulatory control and are not intended to help support or sustain life or be substantially important in preventing impairment to human health, and may not present an unreasonable risk of illness or injury. 18. Examples of Class 1 devices include elastic bandages, examination gloves, and handheld surgical instruments. 19. Class 2 devices are subject to special labeling requirements, mandatory performance standards and post-market surveillance. 19. Examples of Class 2 devices include acupuncture needles, powered wheelchairs, infusion pumps, air purifiers, surgical drapes, stereotaxic navigation systems, and surgical robots. 16, 19, 20, 21, 22. Class 3 devices are usually those that support or sustain human life, are of substantial importance in preventing impairment of human health, or present a potential, unreasonable risk of illness or injury and require pre-market approval. 19, 16. Examples of Class 3 devices include implantable pacemakers, pulse generators, HIV diagnostic tests, automated external defibrillators, and endosseous implants. 19. European Union (EU) and European Free Trade Association (EFTA). The classification of medical devices in the European Union is outlined in Article 9 of the Council Directive 93/42/EEC and Annex 8 of the EU Medical Device Regulation. There are basically 4 classes, ranging from low risk to high risk, classes I, IIA, IIB, and 3. This excludes in vitro diagnostics including software, which fall in 4 classes, from A, lowest risk, to D, highest risk. 23. Device class risk examples. Class 1, Class 1, Class IS, Class IM, Class IR, low risk tongue, wheelchair, spectacles. Class IIA medium risk hearing aids. Class IIB medium to high risk ventilators, infusion pumps. Class 3 high risk pacemakers, defibrillators, implanted prosthetics, breast implants. Class 1 devices, non-invasive, everyday devices or equipment. Class 1 devices are generally low risk and can include bandages, compression hosiery, or walking aids. Such devices require only for the manufacturer to complete a technical file. Class is devices. Class is devices are similarly non-invasive devices, however this subgroup extends to include sterile devices. Examples of Class is devices include stethoscopes, examination gloves, colostomy bags, or oxygen masks. These devices also require a technical file, with the added requirement of an application to a European notified body for certification of manufacturing in conjunction with sterility standards. Class IM devices, this refers chiefly to similarly low-risk measuring devices. Included in this category are thermometers, droppers, and non-invasive blood pressure measuring devices. Once again, the manufacturer must provide a technical file and be certified by a European notified body for manufacturing in accordance with metrology regulations. Class IIA devices. Class IIA devices generally constitute low to medium risk and pertain mainly to devices installed within the body in the short term. Class IIA devices are those which are installed within the body for only between 60 minutes and 30 days. Examples include hearing aids, blood transfusion tubes, and catheters. Requirements include technical files and a conformity test carried out by a European notified body. Class IIB devices, slightly more complex than IIA devices. Class IIB devices are generally medium to high risk and will often be devices installed within the body for periods of 30 days or longer. Examples include ventilators and intensive care monitoring equipment. Identical compliance route to Class IIA devices with an added requirement of a device type examination by a notified body. Class 3 devices. Class 3 devices are strictly high-risk devices. Examples include balloon catheters, prosthetic heart valves, pacemakers, etc. The steps to approval here include a full quality assurance system audit, along with examination of both the device's design and the device itself by a European notified body. The authorization of medical devices is guaranteed by a declaration of conformity. This declaration is issued by the manufacturer itself, but for products in Class IS, IM, IR, IIA, IIB or 3, it must be verified by a certificate of conformity issued by a notified body. A notified body is a public or private organization that has been accredited to validate the compliance of the device to the European directive. Medical devices that pertain to Class I, on condition they do not require sterilization or do not measure a function, can be marketed purely by self-certification. The European classification depends on rules that involve the medical device's duration of body contact, invasive character, use of an energy source, effect on the central circulation or nervous system, diagnostic impact, or incorporation of a medicinal product. Certified medical devices should have the CE mark on the packaging, insert leaflets, etc. These packagings should also show harmonized pictograms and EN standardized logos to indicate essential features such as instructions for use, expiry date, manufacturer, sterile, don't reuse, etc. In November 2018, the Federal Administrative Court of Switzerland decided that the Sympto app, used to analyze a woman's menstrual cycle, was a medical device because it calculates a fertility window for each woman using personal data. The manufacturer, Symptotherm Foundation, argued that this was a didactic, not a medical process. The court laid down that an app is a medical device if it is to be used for any of the medical purposes provided by law, and creates or modifies health information by calculations or comparison, providing information about an individual patient. 24. Japan. Medical devices, excluding in vitro diagnostics, in Japan are classified into 4 classes based on risk. Frowny face 11. Device class risk. Class 1 insignificant. Class 2 low. Class 3 high risk on malfunction. Class 4 high risk could cause life-threatening. Classes 1 and 2 distinguish between extremely low and low risk devices. Classes 3 and 4, moderate and high risk respectively, are highly and specially controlled medical devices. In vitro diagnostics have 3 risk classifications. 25. Rest of the world. For the remaining regions in the world, the risk classifications are generally similar to the United States, European Union, and Japan, or are a variant combining 2 or more of the 3 countries' risk classifications. Citation needed. Australia. The classification of medical devices in Australia is outlined in Section 41BD of the Therapeutic Goods Act 1989 and Regulation 3.2 of the Therapeutic Goods Regulations 2002, under control of the Therapeutic Goods Administration. Similarly to the EU classification, they rank in several categories, by order of increasing risk and associated required level of control. Various rules identify the devices category. 26. Medical device categories in Australia. Classification level of risk. Class 1 low. Class 1 measuring or Class 1 supplied sterile or Class IIA low medium. Class IIB medium high. Class 3 high. Active implantable medical devices, AIMD, high. Canada. Stretchers wait to be used at the York Region EMS Logistics Headquarters in Ontario. The Medical Devices Bureau of Health Canada recognizes 4 classes of medical devices based on the level of control necessary to assure the safety and effectiveness of the device. Class 1 devices present the lowest potential risk and do not require a license. Class 2 devices require the manufacturer's declaration of device safety and effectiveness, whereas Class 3 and 4 devices present a greater potential risk and are subject to in-depth scrutiny. 13. A guidance document for device classification is published by Health Canada. 27. Canadian classes of medical devices correspond to the European Council Directive 93/42/EEC, MDD, devices frowny face. 27. Class 1, Canada, generally corresponds to Class 1, ECD. Class 2, Canada, generally corresponds to Class IIA, ECD. Class 3, Canada, generally corresponds to Class IIB, ECD. Class 4, Canada, generally corresponds to Class 3, ECD. Examples include surgical instruments, Class 1, contact lenses and ultrasound scanners, Class 2, orthopedic implants and hemodialysis machines, Class 3, and cardiac pacemakers, Class 4. 28. India. Medical devices in India are regulated by Central Drug Standard Control Organisation, CDSCO. Medical devices under the Medical Devices Rules, 2017 are classified as per Global Harmonization Task Force, GHTF, based on associated risks. The CDSCO classifications of medical devices govern alongside the regulatory approval and registration by the CDSCO is under the DCGI. Every single medical device in India pursues a regulatory framework that depends on the drug guidelines under the Drug and Cosmetics Act, 1940, and the Drugs and Cosmetics runs under 1945. CDSCO classification for medical devices has a set of risk classifications for numerous products planned for notification and guidelines as medical devices. Citation needed. Device class risk examples. Class A low-risk tongue, wheelchair, spectacles, alcohol swab. Class B low to moderate risk hearing aids, thermometer. Class C moderate to high-risk ventilators, infusion pumps. Class D high-risk pacemakers, defibrillators, implanted prosthetics, breast implants. Iran. Iran produces about 2,000 types of medical devices and medical supplies, such as appliances, dental supplies, disposable sterile medical items, laboratory machines, various biomaterials and dental implants. 400 medical products are produced at the C and D risk class, with all of them licensed by the Iranian Health Ministry in terms of safety and performance based on EU standards. Some Iranian medical devices are produced according to the European Union standards. Some producers in Iran export medical devices and supplies which adhere to European Union standards to applicant countries, including 40 Asian and European countries. Some Iranian producers export their products to foreign countries. 29. Validation and verification. Main article, Validation and verification, medical devices. Validation and verification of medical devices ensure that they fulfill their intended purpose. Validation or verification is generally needed when a health facility acquires a new device to perform medical tests. Citation needed. The main difference between the two is that validation is focused on ensuring that the device meets the needs and requirements of its intended users and the intended use environment, whereas verification is focused on ensuring that the device meets its specified design requirements. Citation needed. Standardization and regulatory concerns. The ISO standards for medical devices are covered by ICS 11.100.20 and 11.040.01, 30, 31. The quality and risk management regarding the topic for regulatory purposes is convened by ISO 13485 and ISO 14971. ISO 13485:2016 is applicable to all providers and manufacturers of medical devices, components, contract services and distributors of medical devices. The standard is the basis for regulatory compliance in local markets, and most export markets. 32, 33, 34. Additionally, ISO 9001:2008 sets precedents because it signifies that a company engages in the creation of new products. It requires that the development of manufactured products have an approval process and a set of rigorous quality standards and development records before the product is distributed. 35. Further standards are IEC 60601-1, which is for electrical devices, mains powered as well as battery powered. EN 45502-1, which is for active implantable medical devices, and IEC 62304 for medical software. The US FDA also published a series of guidances for industry regarding this topic against 21 CFR 820 Subchapter H, Medical Devices. 36. Subpart B includes quality system requirements, an important component of which are design controls. 21 CFR 820.30. To meet the demands of these industry regulation standards, a growing number of medical device distributors are putting the complaint management process at the forefront of their quality management practices. This approach further mitigates risks and increases visibility of quality issues. 37. Starting in the late 1980s, 38, the FDA increased its involvement in reviewing the development of medical device software. The precipitant for change was a radiation therapy device, Therac 25, that overdosed patients because of software coding errors. 39. FDA is now focused on regulatory oversight on medical device software development process and system-level testing. 40. A 2011 study by Diana Zuckerman and Paul Brown of the National Center for Health Research, and Dr. Stephen Neeson of the Cleveland Clinic, published in the Archives of Internal Medicine, showed that most medical devices recalled in the last 5 years for serious health problems or death had been previously approved by the FDA using the less stringent, and cheaper, 510(k) process. In a few cases, the devices had been deemed so low risk that they did not undergo any FDA regulatory review. Of the 113 devices recalled, 35 were for cardiovascular issues. 41. This study was the topic of congressional hearings reevaluating FDA procedures and oversight. A 2014 study by Diana Zuckerman, Paul Brown, and Dr. Aditi Das of the National Center for Health Research, published in JAMA Internal Medicine, examined the scientific evidence that is publicly available about medical implants that were cleared by the FDA 510(k) process from 2008 to 2012. They found that scientific evidence supporting substantial equivalence to other devices already on the market was required by law to be publicly available, but the information was available for only 16% of the randomly selected implants, and only 10% provided clinical data. Of the more than 1,100 predicate implants that the new implants were substantially equivalent to, only 3% had any publicly available scientific evidence, and only 1% had clinical evidence of safety or effectiveness. 42. The researchers concluded that publicly available scientific evidence on implants was needed to protect the public health. Citation needed. In 2014 to 2015, a new international agreement, the Medical Device Single Audit Program, MDSAP, was put in place with 5 participant countries: Australia, Brazil, Canada, Japan, and the United States. The aim of this program was to develop a process that allows a single audit or inspection to ensure the medical device regulatory requirements for all 5 countries are satisfied. 43. In 2017, a study by Dr. J. Ronquillo and Dr. Diana Zuckerman published in the peer-reviewed policy journal Millbank Quarterly found that electronic health records and other device software were recalled due to life-threatening flaws. The article pointed out the lack of safeguards against hacking and other cybersecurity threats, stating current regulations are necessary but not sufficient for ensuring patient safety by identifying and eliminating dangerous defects in software currently on the market. 44. They added that legislative changes resulting from the law entitled the 21st Century Cures Act will further deregulate health IT, reducing safeguards that facilitate the reporting and timely recall of flawed medical software that could harm patients. A study by Dr. Stephanie Fox Rawlings and colleagues at the National Center for Health Research, published in 2018 in the policy journal Millbank Quarterly, investigated whether studies reviewed by the FDA for high-risk medical devices are proven safe and effective for women, minorities, or patients over 65 years of age. 45. The law encourages patient diversity in clinical trials submitted to the FDA for review, but does not require it. The study determined that most high-risk medical devices are not tested and analyzed to ensure that they are safe and effective for all major demographic groups, particularly racial and ethnic minorities and people over 65. Therefore, they do not provide information about safety or effectiveness that would help patients and physicians make well-informed decisions. In 2018, an investigation involving journalists across 36 countries coordinated by the International Consortium of Investigative Journalists, ICIJ, prompted calls for reform in the United States, particularly around the 510(k) K. Substantial equivalence process wink with a frown 46. The investigation prompted similar calls in the UK and Europe Union. 47. Packaging standards. Curette in sterile pouch. Porous Tyvek material allows gas sterilization. Medical device packaging is highly regulated. Often medical devices and products are sterilized in the package. 48. Sterility must be maintained throughout distribution to allow immediate use by physicians. A series of special packaging tests measure the ability of the package to maintain sterility. Relevant standards include ASTM F2097, Standard Guide for Design and Evaluation of Primary Flexible Packaging for Medical Products. ASTM F2475-11, Standard Guide for Biocompatibility Evaluation of Medical Device Packaging Materials. 49. EN 868 Packaging Materials and Systems for Medical Devices to be Sterilized, General Requirements and Test Methods. ISO 11607 Packaging for Terminally Sterilized Medical Devices. Package testing is part of a quality management system including verification and validation. It is important to document and ensure that packages meet regulations and end-use requirements. Manufacturing processes must be controlled and validated to ensure consistent performance. 50. 51. EN ISO 15223-1 defines symbols that can be used to convey important information on packaging and labeling. Biocompatibility standards. ISO 10993, Biological Evaluation of Medical Devices. Cleanliness standards. Medical device cleanliness has come under greater scrutiny since 2000, when Sulzer Orthopedics recalled several thousand metal hip implants that contained a manufacturing residue. 52. Based on this event, ASTM established a new task group, F04.15.17, for established test methods, guidance documents, and other standards to address cleanliness of medical devices. This task group has issued 2 standards for permanent implants to date. 1. ASTM F2459, Standard Test Method for Extracting Residue from Metallic Medical Components and Quantifying via Gravimetric Analysis. 53. 2. ASTM F2847, Standard Practice for Reporting and Assessment of Residues on Single-Use Implants. 54. 3. ASTM F3172, Standard Guide for Validating Cleaning Processes Used During the Manufacture of Medical Devices. 55. In addition, the cleanliness of reusable devices has led to a series of standards, including ASTM E2314, Standard Test Method for Determination of Effectiveness of Cleaning Processes for Reusable Medical Instruments Using a Microbiologic Method, Simulated Use Test. 56. ASTM D7225, Standard Guide for Blood Cleaning Efficiency of Detergents and Washer Disinfectors. 57. ASTM F3208, Standard Guide for Selecting Test Soils for Validation of Cleaning Methods for Reusable Medical Devices. 55. The ASTM F04.15.17 task group is working on several new standards that involve designing implants for cleaning, selection and testing of brushes for cleaning reusable devices, and cleaning assessment of medical devices made by additive manufacturing. 58. Additionally, the FDA is establishing new guidelines for reprocessing reusable medical devices, such as orthoscopic shavers, endoscopes, and suction tubes. 59. New research was published in ACS Applied Interfaces and Material to Keep Medical Tools Pathogen-Free. 60. Safety Standards. Main article, Safety Standards. Design, Prototyping, and Product Development. Main article, Medical Device Manufacturing. Medical device manufacturing requires a level of process control according to the classification of the device. Higher risk, more controls. When in the initial R&D phase, manufacturers are now beginning to design for manufacturability. This means products can be more precision engineered for production to result in shorter lead times, tighter tolerances and more advanced specifications and prototypes. These days, with the aid of CAD or modeling platforms, the work is now much faster, and this can act also as a tool for strategic design generation as well as a marketing tool. 61. Failure to meet cost targets will lead to substantial losses for an organization. In addition, with global competition, the R&D of new devices is not just a necessity, it is an imperative for medical device manufacturers. The realization of a new design can be very costly, especially with the shorter product life cycle. As technology advances, there is typically a level of quality, safety and reliability that increases exponentially with time. 61. For example, initial models of the artificial cardiac pacemaker were external support devices that transmits pulses of electricity to the heart muscles via electrode leads on the chest. The electrodes contact the heart directly through the chest, allowing stimulation pulses to pass through the body. Recipients of this typically developed an infection at the entrance of the electrodes, which led to the subsequent trial of the first internal pacemaker, with electrodes attached to the myocardium by thoracotomy. Future developments led to the isotope power source that would last for the lifespan of the patient. Page needed. Software. Main article, Medical Software. Mobile Medical Applications. With the rise of smartphone usage in the medical space, in 2013, the FDA issued to regulate mobile medical applications and protect users from their unintended use, soon followed by European and other regulatory agencies. This guidance distinguishes the apps subjected to regulation based on the marketing claims of the apps. 62. Incorporation of the guidelines during the development phase of such apps can be considered as developing a medical device. The regulations have to adapt and propositions for expedite approval may be required due to the nature of versions of mobile application development. 63. 64. On September 25, 2013, the FDA released a draft guidance document for regulation of mobile medical applications, to clarify what kind of mobile apps related to health would not be regulated, and which would be. 65. 66. Cybersecurity. Further information, medical device hijack. Medical devices such as pacemakers, insulin pumps, operating room monitors, defibrillators, and surgical instruments, including deep brain stimulators, can incorporate the ability to transmit vital health information from a patient's body to medical professionals. 67. Some of these devices can be remotely controlled. This has engendered concern about privacy and security issues. 68. 69. Human error and technical glitches with this technology. While only a few studies have looked at the susceptibility of medical devices to hacking, there is a risk. 70. 71. 72. In 2008, computer scientists proved that pacemakers and defibrillators can be hacked wirelessly via radio hardware, an antenna, and a personal computer. 73. 74. 75. These researchers showed they could shut down a combination heart defibrillator and pacemaker and reprogram it to deliver potentially lethal shocks or run out its battery. J. Radcliffe, a security researcher interested in the security of medical devices, raised fears about the safety of these devices. He shared his concerns at the Black Hat Security Conference. 76. Radcliffe fears that the devices are vulnerable and has found that a lethal attack is possible against those with insulin pumps and glucose monitors. Some medical device makers downplay the threat from such attacks and argue that the demonstrated attacks have been performed by skilled security researchers and are unlikely to occur in the real world. At the same time, other makers have asked software security experts to investigate the safety of their devices. 77. As recently as June 2011, security experts showed that by using readily available hardware and a user manual, a scientist could both tap into the information on the system of a wireless insulin pump in combination with a glucose monitor. With the pin of the device, the scientist could wirelessly control the dosage of the insulin. 78. Anand Raghunathan, a researcher in this study, explains that medical devices are getting smaller and lighter so that they can be easily worn. The downside is that additional security features would put an extra strain on the battery and size and drive up prices. Dr. William Maisel offered some thoughts on the motivation to engage in this activity. Motivation to do this hacking might include acquisition of private information for financial gain or competitive advantage, damage to a device manufacturer's reputation, sabotage, intent to inflict financial or personal injury, or just satisfaction for the attacker. 79. Researchers suggest a few safeguards. One would be to use rolling codes. Another solution is to use a technology called body-coupled communication that uses the human skin as a waveguide for wireless communication. On December 28, 2016, the U.S. Food and Drug Administration released its recommendations that are not legally enforceable for how medical device manufacturers should maintain the security of Internet-connected devices. 80. 81. Similar to hazards, cybersecurity threats and vulnerabilities cannot be eliminated but must be managed and reduced to a reasonable level. 82. When designing medical devices, the tier of cybersecurity risk should be determined early in the process in order to establish a cybersecurity vulnerability and management approach, including a set of cybersecurity design controls. The medical device design approach employed should be consistent with the NIST cybersecurity framework for managing cybersecurity-related risks. In August 2013, the FDA released over 20 regulations aiming to improve the security of data in medical devices, 83, in response to the growing risks of limited cybersecurity. Artificial intelligence. The number of approved medical devices using artificial intelligence or machine learning, AI or ML, is increasing. As of 2020, there were several hundred AI or ML medical devices approved by the US FDA or CE mark devices in Europe, 84, 85, 86. Most AI or ML devices focus upon radiology. As of 2020, there was no specific regulatory pathway for AI/ML-based medical devices in the US or Europe, 87, 85, 86. However, in January 2021, the FDA published a proposed regulatory framework for AI/ML-based software, 88, 89, and the EU Medical Device Regulation, which replaces the EU Medical Device Directive in May 2021, defines regulatory requirements for medical devices, including AI or ML software. 90. Types. There are several basic types. Diagnostic equipment includes medical imaging machines used to aid in diagnosis. Examples are ultrasound and MRI machines, PET and CT scanners, and X-ray machines. Treatment equipment includes infusion pumps, medical lasers and LASIK surgical machines. Life support equipment is used to maintain a patient's bodily function. This includes medical ventilators, incubators, anesthetic machines, heart-lung machines, ECMO, and dialysis machines. Medical monitors allow medical staff to measure a patient's medical state. Monitors may measure patient vital signs and other parameters including ECG, EEG, and blood pressure. Medical laboratory equipment automates or helps analyze blood, urine, genes, and dissolved gases in the blood. Diagnostic medical equipment may also be used in the home for certain purposes, e.g. for the control of diabetes mellitus, such as in the case of continuous glucose monitoring. Therapeutic, physical therapy machines like continuous passive range of motion, CPM, machines. Air purifying equipment may be used in the periphery of the operating room, 92, or at point sources including near the surgical site for the removal of surgical plume, 93. The identification of medical devices has been recently improved by the introduction of Unique Device Identification, UDI, and standardized naming using the Global Medical Device Nomenclature, GMDN, which have been endorsed by the International Medical Device Regulatory Forum, IMDRF. 94. A biomedical equipment technician, BMET, is a vital component of the healthcare delivery system. Employed primarily by hospitals, METs are the people responsible for maintaining a facility's medical equipment. BMET mainly act as an interface between doctor and equipment. Medical equipment donation. There are challenges surrounding the availability of medical equipment from a global health perspective, with low-resource countries unable to obtain or afford essential and life-saving equipment. In these settings, well-intentioned equipment donation from high to low-resource settings is a frequently used strategy to address this through individuals, organizations, manufacturers, and charities. However, issues with maintenance, availability of biomedical equipment technicians, BMET, supply chains, user education, and the appropriateness of donations means these frequently fail to deliver the intended benefits. The WHO estimates that 95% of medical equipment in low- and middle-income countries, (MICs), is imported and 80% of it is funded by international donors or foreign governments. While up to 70% of medical equipment in sub-Saharan Africa is donated, only 10% to 30% of donated equipment becomes operational. 95. A review of current practice and guidelines for the donation of medical equipment for surgical and anesthesia care in LMICs has demonstrated a high level of complexity within the donation process and numerous shortcomings. Greater collaboration and planning between donors and recipients is required together with evaluation of donation programs and concerted advocacy to educate donors and recipients on existing equipment donation guidelines and policies. 96. The circulation of medical equipment is not limited to donations. The rise of reuse and recycle-based solutions, where gently used medical equipment is donated and redistributed to communities in need, is another form of equipment distribution. An interest in reusing and recycling emerged in the 1980s when the potential health hazards of medical waste on the East Coast beaches became highlighted by the media. 97, connecting the large demand for medical equipment and single-use medical devices, with a need for waste reduction, as well as the problem of unequal access for low-income communities, led to the Congress enacting the Medical Waste Tracking Act of 1988. 98, medical equipment can be donated either by governments or non-governmental organizations, domestic or international. 99, donated equipment ranges from bedside assistance to radiological equipment. Medical equipment donation has come under scrutiny with regard to donated device failure and loss of warranty in the case of previous ownership. Most medical devices and production company warranties do not extend to reused or donated devices, or to devices donated by initial owners/patients. Such reuse raises matters of patient autonomy, medical ethics, and legality. 99, such concerns conflict with the importance of equal access to healthcare resources, and the goal of serving the greatest good for the greatest number. 100. Academic resources. Medical and Biological Engineering and Computing Journal. Expert Review of Medical Devices Journal. University-based research, Packaging Institutes. University of Minnesota Medical Devices Center, MDC. University of Strathclyde Institute of Medical Devices, SIMD. Flinders University Medical Device Research Institute, MDRI. Michigan State University School of Packaging, SOP, 101. IIT Bombay Biomedical Engineering and Technology, Incubation Center, BETC. See also. Assistive Technology. Clinical Engineer. Design History File. Durable Medical Equipment. Electromagnetic Compatibility. Electronic Health Record. Federal Institute for Drugs and Medical Devices. GHTF. Health Level 7. Home Medical Equipment. Instruments used in general medicine. List of common EMC test standards. Medical grade silicone. Medical logistics. Medical technology. Pharmacopoeia. Safety engineer. Telemedicine. The stethoscope is a medical device for auscultation, or listening to internal sounds of an animal or human body. It typically has a small disc-shaped resonator that is placed against the skin, with either one or two tubes connected to two earpieces. A stethoscope can be used to listen to the sounds made by the heart, lungs, or intestines, as well as blood flow in arteries and veins. In combination with a manual sphygmomanometer, it is commonly used when measuring blood pressure. Less commonly, mechanic stethoscopes, equipped with rod-shaped chest pieces, are used to listen to internal sounds made by machines, for example, sounds and vibrations emitted by worn ball bearings, such as diagnosing a malfunctioning automobile engine by listening to the sounds of its internal parts. Stethoscopes can also be used to check scientific vacuum chambers for leaks and for various other small-scale acoustic monitoring tasks. A stethoscope that intensifies auscultatory sounds is called a phonendoscope. A girl having her heart listened to with a stethoscope. History. This early stethoscope belonged to Laennec. Science Museum, London. Early stethoscopes. A Traube-type stethoscope in ivory. The stethoscope was invented in France in 1816 by René Laennec at the Necker-Enfants Malades Hospital in Paris. 1, 2, 3. It consisted of a wooden tube and was monaural. Laennec invented the stethoscope because he was not comfortable placing his ear directly onto a woman's chest in order to listen to her heart. 4, 5. 186. He observed that a rolled piece of paper, placed between the individual's chest and his ear, could amplify heart sounds without requiring physical contact. 6. Laennec's device was similar to the common ear trumpet, a historical form of hearing aid. Indeed, his invention was almost indistinguishable in structure and function from the trumpet, which was commonly called a microphone. Laennec called his device the stethoscope. 7. Stetho plus scope, chest scope, and he called its use mediate auscultation, because it was auscultation with a tool intermediate between the individual's body and the physician's ear. Today the word auscultation denotes all such listening, mediate or not. The first flexible stethoscope of any sort may have been a binaural instrument with articulated joints not very clearly described in 1829. 8. In 1840, Golding Bird described a stethoscope he had been using with a flexible tube. Bird was the first to publish a description of such a stethoscope, but he noted in his paper the prior existence of an earlier design, which he thought was of little utility, which he described as the snake ear trumpet. Bird's stethoscope had a single earpiece. 9. In 1851, Irish physician Arthur Laird invented a binaural stethoscope, and in 1852, George Philip Kamen perfected the design of the stethoscope instrument, that used both ears, for commercial production, which has become the standard ever since. Kamen also wrote a major treatise on diagnosis by auscultation, which the refined binaural stethoscope made possible. By 1873, there were descriptions of a differential stethoscope that could connect to slightly different locations to create a slight stereo effect, though this did not become a standard tool in clinical practice. Somerville Scott Allison described his invention of the stethophone at the Royal Society in 1858. The stethophone had two separate bells, allowing the user to hear and compare sounds derived from two discrete locations. This was used to do definitive studies on binaural hearing and auditory processing that advanced knowledge of sound localization and eventually lead to an understanding of binaural fusion. 1. The medical historian Jacqueline Duffin has argued that the invention of the stethoscope marked a major step in the redefinition of disease from being a bundle of symptoms to the current sense of a disease as a problem with an anatomical system even if there are no observable symptoms. This reconceptualization occurred in part, Duffin argues, because prior to stethoscopes, there were no non-lethal instruments for exploring internal anatomy. 10. Rappaport and Sprague designed a new stethoscope in the 1940s, which became the standard by which other stethoscopes are measured, consisting of two sides, one of which is used for the respiratory system, the other for the cardiovascular system. The Rappaport-Sprague was later made by Hewlett-Packard. HP's Medical Products division was spun off as part of Agilent Technologies Incorporated, where it became Agilent Healthcare. Agilent Healthcare was purchased by Philips, which became Philips Medical Systems. Before the walnut-boxed, $300, original Rappaport-Sprague stethoscope was finally abandoned ca. 2004, along with Philips brand, manufactured by Andromd, of Montreal, Canada, electronic stethoscope model. The Rappaport-Sprague model stethoscope was heavy and short, 18 to 24 in, 46 to 61 centimeters, with an antiquated appearance recognizable by their two large independent latex rubber tubes connecting an exposed leaf spring joint pair of opposing F-shaped chrome-plated brass binaural ear tubes with a dual-head chest piece. Early flexible tube stethoscopes. Golding Bird's instrument is on the left. The instrument on the right is the stethophone. 1. Several other minor refinements were made to stethoscopes until, in the early 1960s, David Littman, a Harvard Medical School professor, created a new stethoscope that was lighter than previous models and had improved acoustics. 11. 12. In the late 1970s, 3M Littman introduced the tunable diaphragm, a very hard, G10, glass epoxy resin diaphragm member with an overmolded silicone flexible acoustic surround which permitted increased excursion of the diaphragm member in a z-axis with respect to the plane of the sound collecting area. 13. The left shift to a lower resonant frequency increases the volume of some low-frequency sounds due to the longer waves propagated by the increased excursion of the hard diaphragm member suspended in the concentric acoustic surround. Conversely, restricting excursion of the diaphragm by pressing the stethoscope diaphragm surface firmly against the anatomical area overlying the physiological sounds of interest, the acoustic surround could also be used to dampen excursion of the diaphragm in response to z-axis pressure against a concentric fret. This raises the frequency bias by shortening the wavelength to auscultate a higher range of physiological sounds. In 1999, Richard Deslauriers patented the first external noise-reducing stethoscope, the DRG Puretone. It featured two parallel lumens containing two steel coils which dissipated infiltrating noise as inaudible heat energy. The steel coil insulation added 0.30 lb to each stethoscope. In 2005, DRG's diagnostics division was acquired by Trimline Medical Products. 14. Failed verification. Current practice. A doctor using a stethoscope on a patient's abdomen to listen to bowel sounds. Stethoscopes are a symbol of healthcare professionals. Healthcare providers are often seen or depicted wearing a stethoscope around the neck. A 2012 research paper claimed that the stethoscope, when compared to other medical equipment, had the highest positive impact on the perceived trustworthiness of the practitioner seen with it. 15. 16. Prevailing opinions on the utility of the stethoscope in current clinical practice vary depending on the medical specialty. Studies have shown that auscultation skill, i.e., the ability to make a diagnosis based on what is heard through a stethoscope, has been in decline for some time, such that some medical educators are working to re-establish it. 17, 18, 19. In general practice, traditional blood pressure measurement using a mechanical sphygmomanometer with inflatable cuff and stethoscope is gradually being replaced with automated blood pressure monitors. 20. Acoustic. Parts of a binaural stethoscope. Acoustic stethoscope, with the bell upwards. Acoustic stethoscopes operate on the transmission of sound from the chest piece, via air-filled hollow tubes, to the listener's ears. The chest piece usually consists of two sides that can be placed against the patient for sensing sound, a diaphragm, plastic disc, or bell, hollow cup. If the diaphragm is placed on the patient, body sounds vibrate the diaphragm, creating acoustic pressure waves which travel up the tubing to the listener's ears. If the bell is placed on the patient, the vibrations of the skin directly produce acoustic pressure waves traveling up to the listener's ears. The bell transmits low-frequency sounds, while the diaphragm transmits higher frequency sounds. To deliver the acoustic energy primarily to either the bell or diaphragm, the tube connecting into the chamber between bell and diaphragm is open on only one side and can rotate. The opening is visible when connected into the bell. Rotating the tube 180 degrees in the head connects it to the diaphragm. This two-sided stethoscope was invented by Rappaport and Sprague in the early part of the 20th century. Citation needed. Electronic stethoscope. An electronic stethoscope, or stethophone, overcomes the low sound levels by electronically amplifying body sounds. However, amplification of stethoscope contact artifacts, and component cutoffs, frequency response thresholds of electronic stethoscope microphones, preamps, amps, and speakers, limit electronically amplified stethoscopes' overall utility by amplifying mid-range sounds, while simultaneously attenuating high and low-frequency range sounds. Currently, a number of companies offer electronic stethoscopes. Electronic stethoscopes require conversion of acoustic sound waves to electrical signals which can then be amplified and processed for optimal listening. Unlike acoustic stethoscopes, which are all based on the same physics, transducers in electronic stethoscopes vary widely. The simplest and least effective method of sound detection is achieved by placing a microphone in the chest piece. This method suffers from ambient noise interference and has fallen out of favor. Another method, used in Welchallen's Metatron stethoscope, comprises placement of a piezoelectric crystal at the head of a metal shaft, the bottom of the shaft making contact with the diaphragm. 3M also uses a piezoelectric crystal placed within foam behind a thick rubber-like diaphragm. The ThinkLab's Rhythm 32 uses an electromagnetic diaphragm with a conductive inner surface to form a capacitive sensor. This diaphragm responds to sound waves, with changes in an electric field replacing changes in air pressure. The EcoCore enables wireless transmission of heart sounds to a smartphone or tablet. The EcoDuo can take electrocardiograms as well as echocardiograms. This enables clinicians to screen for conditions such as heart failure, which would not be possible with a traditional stethoscope. 21, 22. Because the sounds are transmitted electronically, an electronic stethoscope can be a wireless device, can be a recording device, and can provide noise reduction, signal enhancement, and both visual and audio output. Around 2001, Stethographics introduced PC-based software which enabled a phonocardiograph, graphic representation of cardiologic and pulmonologic sounds to be generated and interpreted according to related algorithms. All of these features are helpful for purposes of telemedicine, remote diagnosis, and teaching. Citation needed. Electronic stethoscopes are also used with computer-aided auscultation programs to analyze the recorded heart sounds, pathological or innocent heart murmurs. Recording. Some electronic stethoscopes feature direct audio output that can be used with an external recording device, such as a laptop or MP3 recorder. The same connection can be used to listen to the previously recorded auscultation through the stethoscope headphones, allowing for more detailed study for general research as well as evaluation and consultation regarding a particular patient's condition and telemedicine, or remote diagnosis. 23. There are some smartphone apps that can use the phone as a stethoscope. 24. At least one uses the phone's own microphone to amplify sound, produce a visualization, and email the results. These apps may be used for training purposes or as novelties, but have not yet gained acceptance for professional medical use. 25. The first stethoscope that could work with a smartphone application was introduced in 2015. 26. Fetal. A penard horn used by a U.S. Army Reserve nurse in Uganda. Main article, penard horn. A fetal stethoscope or fetoscope is an acoustic stethoscope shaped like a listening trumpet. It is placed against the abdomen of a pregnant woman to listen to the heart sounds of the fetus. 27. The fetal stethoscope is also known as a Pinard horn after French obstetrician Adolphe Pinard, 1844–1934. Doppler. A Doppler stethoscope is an electronic device that measures the Doppler effect of ultrasound waves reflected from organs within the body. Motion is detected by the change in frequency, due to the Doppler effect, of the reflected waves. Hence the Doppler stethoscope is particularly suited to deal with moving objects such as a beating heart. 28. It was recently demonstrated that continuous Doppler enables the auscultation of valvular movements and blood flow sounds that are undetected during cardiac examination with a stethoscope in adults. The Doppler auscultation presented a sensitivity of 84% for the detection of aortic regurgitations, while classic stethoscope auscultation presented a sensitivity of 58%. Moreover, Doppler auscultation was superior in the detection of impaired ventricular relaxation. Since the physics of Doppler auscultation and classic auscultation are different, it has been suggested that both methods could complement each other. 29. 30. A military noise-immune Doppler-based stethoscope has recently been developed for auscultation of patients in loud sound environments, up to 110 dB. 3D printed. A 3D printed stethoscope. A 3D printed stethoscope is an open-source medical device meant for auscultation and manufactured via means of 3D printing. 31. The 3D stethoscope was developed by Dr. Tariq Labani and a team of medical and technology specialists. The 3D stethoscope was developed as part of the GLIA project, and its design is open source from the outset. The stethoscope gained widespread media coverage in summer 2015. The need for a 3D stethoscope was born out of a lack of stethoscopes and other vital medical equipment because of the blockade of the Gaza Strip, where Labani, a Palestinian Canadian, worked as an emergency physician during the 2012 conflict in Gaza. The 1960s-era Littman Cardiology 3 stethoscope became the basis for the 3D printed stethoscope developed by Labani. 32. Esophageal. Prior to the 1960s, the esophageal stethoscope was a part of the routine intraoperative monitoring. 33. Earpieces. Stethoscopes usually have rubber earpieces, which aid comfort and create a seal with the ear, improving the acoustic function of the device. Stethoscopes can be modified by replacing the standard earpieces with molded versions, which improve comfort and transmission of sound. Molded earpieces can be cast by an audiologist or made by the stethoscope user from a kit. See also. Icon Medicine Portal. Doppler fetal monitor. Speaking tube. A tongue depressor or spatula is a tool used in medical practice to depress the tongue to allow for examination of the mouth and throat. Hobbyists, artists, teachers, and confectionery makers use tongue depressors, which may be referred to as craft sticks or popsicle sticks. Description. A tongue depressor is a tool used in medical practice to depress the tongue to allow for examination of the mouth and throat. For this use, it is also known as a spatula. 1. History. Earlier versions of depressors were made from balsa, pine, or redwood woods. Tongue depressors made from wood and metal exist from the American Civil War. 2. The most common modern tongue depressors are flat, thin, wooden blades, smoothed and rounded at both ends. 3. But, historically, tongue depressors have been made of a variety of materials. 4. Since they are inexpensive and difficult to clean because of their porous texture, wooden tongue depressors are labeled for disposal after a single usage. 5. Other uses. Ice pops and ice cream bars have used wooden tongue depressors to hold the confection, leading to the name popsicle sticks. Hobbyists, artists, and teachers use wooden tongue depressors in sculptural projects, which has led to the name craft sticks. 6. 7. References. Spatula, Collins Dictionary of Medicine, Robert M. Youngson 2004, 2005. Civil War Consenus, New York Hospital Inventory List Inventory. November 19, 2009. Archived from the original on November 19, 2009. Retrieved April 7, 2023. Definition of tongue depressor. www.merriam-webster.com. Cohen, J. Solis. Diseases of the Throat and Nasal Passages, A Guide to the Diagnosis and Treatment of Affections of the Pharynx, Esophagus, Trachea, Larynx, and Nares. Chapter 2, Examination of the Throat and Nasal Passages. Published by W. Wood, 1884, 742 pp. Landro, Laura. Hospitals reuse medical devices to lower costs. Wall Street Journal. Kentwood, Rick Laban. N-Scale Model Railroad that Grows Kalmbach Publishing Company, 1996. Labrita Gilbert, Linda Gregg. Do Touch, Instant, Easy Hands-On Learning Experiences for Young Children published by Griffin House Incorporated, 1989. External links. VCU Library's Medical Artifacts Collection, Tongue Depressors archived March 4, 2016 at the Wayback Machine. Stub icon. This article related to medical equipment is a stub. You can help Wikipedia by expanding it. Signs and symptoms are the observed or detectable signs and experienced symptoms of an illness, injury, or condition. Signs are objective and externally observable. Symptoms are a person's reported subjective experiences. 1. A sign, for example, may be a higher or lower temperature than normal, raised or lowered blood pressure, or an abnormality showing on a medical scan. A symptom is something out of the ordinary that is experienced by an individual, such as feeling feverish, a headache, or other pains in the body. 2. 3. Signs and symptoms. Signs. A medical sign is an objective observable indication of a disease, injury, or medical condition that may be detected during a physical examination. 4. These signs may be visible, such as a rash or bruise, or otherwise detectable, such as by using a stethoscope or taking blood pressure. Medical signs, along with symptoms, help in forming a diagnosis. Some examples of signs are nail clubbing of either the fingernails or toenails, an abnormal gait, and a limbal ring, a darkened ring around the iris of the eye. Indications. Main article, Indication, Medicine. A sign is different from an indication, the activity of a condition pointing to, thus indicating, a remedy, not the reverse, viz., it is not a remedy pointing to a condition. 5. Which is a specific reason for using a particular treatment, clarification needed. Symptoms. A symptom is something felt or experienced, such as pain or dizziness. Signs and symptoms are not mutually exclusive. For example, a subjective feeling of fever can be noted as sign by using a thermometer that registers a high reading. 6. The CDC lists various diseases by their signs and symptoms, such as for measles, which includes a high fever, conjunctivitis, and cough, followed a few days later by the measles rash. 7. Cardinal signs and symptoms. Cardinal signs and symptoms are specific even to the point of being pathognomonic. A cardinal sign or cardinal symptom can also refer to the major sign or symptom of a disease. 8. Abnormal reflexes can indicate problems with the nervous system. Signs and symptoms are also applied to physiological states outside the context of disease, as for example when referring to the signs and symptoms of pregnancy, or the symptoms of dehydration. Sometimes a disease may be present without showing any signs or symptoms when it is known as being asymptomatic. 9. The disorder may be discovered through tests including scans. An infection may be asymptomatic, which may still be transmissible. 9. Syndrome. Main article, Syndrome. Signs and symptoms are often nonspecific, but some combinations can be suggestive of certain diagnoses, helping to narrow down what may be wrong. A particular set of characteristic signs and symptoms that may be associated with a disorder is known as a syndrome. In cases where the underlying cause is known, the syndrome is named as, for example, Down syndrome and Noonan syndrome. Other syndromes, such as acute coronary syndrome, may have a number of possible causes. Terms. When a disease is evidenced by symptoms, it is known as symptomatic. There are many conditions, including subclinical infections, that display no symptoms, and these are termed asymptomatic. Signs and symptoms may be mild or severe, brief or longer lasting when they may become reduced, remission, or then recur, relapse or recrudescence, known as a flare-up. A flare-up may show more severe symptoms. 10. The term chief complaint, also presenting problem, is used to describe the initial concern of an individual when seeking medical help, and once this is clearly noted, a history of the present illness may be taken. The symptom that ultimately leads to a diagnosis is called a cardinal symptom. Citation needed. Some symptoms can be misleading as a result of referred pain, where for example a pain in the right shoulder may be due to an inflamed gallbladder and not to presumed muscle strain. 11. Many diseases have an early prodromal stage where a few signs and symptoms may suggest the presence of a disorder before further specific symptoms may emerge. Measles, for example, has a prodromal presentation that includes a hacking cough, fever, and Koplik spots in the mouth. 12. Over half of migraine episodes have a prodromal phase. 13. Schizophrenia has a notable prodromal stage. 14. As has dementia. 15. Nonspecific symptoms. Some symptoms are specific, that is, they are associated with a single, specific medical condition. Nonspecific symptoms, sometimes also called equivocal symptoms, 16, are not specific to a particular condition. They include unexplained weight loss, headache, pain, fatigue, loss of appetite, night sweats, and malaise. 17, a group of 3 particular nonspecific symptoms, fever, night sweats, and weight loss, over a period of 6 months are termed B symptoms associated with lymphoma and indicate a poor prognosis. 18. Other subtypes of symptoms include constitutional or general symptoms, which affect general well-being or the whole body, such as a fever wink with a frown. 19. 20. Concomitant symptoms, which are symptoms that occur at the same time as the primary symptom wink with a frown. 21. Prodromal symptoms, which are the first symptoms of a bigger set of problems. Wink with a frown. 22. Delayed symptoms, which happen sometime after the trigger. Wink with a frown. 23, and objective symptoms, which are symptoms whose existence can be observed and confirmed by a healthcare provider. 24. Vital signs. Vital signs are the 4 signs that can give an immediate measurement of the body's overall functioning and health status. They are temperature, heart rate, breathing rate, and blood pressure. The ranges of these measurements vary with age, weight, gender, and with general health. 25. A digital application has been developed for use in clinical settings that measures 3 of the vital signs, not temperature, using just a smartphone, and has been approved by NHS England. The application is registered as LifeLight First, and LifeLight Home is under development, 2020, for monitoring use by people at home using just the camera on their smartphone or tablet. This will additionally measure oxygen saturation and atrial fibrillation. Other devices are then not needed. 26. Syndromes. Further information, list of syndromes and list of medical triads, tetrads, and pentads. Many conditions are indicated by a group of known signs, or signs and symptoms. These can be a group of 3 known as a triad, a group of 4 known as a tetrad, and a group of 5 known as a petrad. An example of a triad is Meltzer's triad presenting purpura, a rash, arthralgia, painful joints, and myalgia, painful and weak muscles. Meltzer's triad indicates the condition cryoglobulinemia. Huntington's disease is a neurodegenerative disease that is characterized by a triad of motor, cognitive, and psychiatric signs and symptoms. 27. A large number of these groups that can be characteristic of a particular disease are known as a syndrome. Noonan syndrome, for example, has a diagnostic set of unique facial and musculoskeletal features. 28. Some syndromes such as nephrotic syndrome may have a number of underlying causes that are all related to diseases that affect the kidneys. 29. Sometimes a child or young adult may have symptoms suggestive of a genetic disorder that cannot be identified even after genetic testing. In such cases the term SWAN, syndrome without a name, may be used. Often a diagnosis may be made at some future point when other more specific symptoms emerge, but many cases may remain undiagnosed. The inability to diagnose may be due to a unique combination of symptoms or an overlap of conditions, or to the symptoms being atypical of a known disorder, or to the disorder being extremely rare. 30. Positive and negative. Positive and negative. Sensory symptoms can also be described as positive symptoms, or as negative symptoms depending on whether the symptom is abnormally present such as tingling or itchiness, or abnormally absent such as loss of smell. The following terms are used for negative symptoms. Hypoesthesia is a partial loss of sensitivity to moderate stimuli, such as pressure, touch, warmth, cold. Anesthesia is the complete loss of sensitivity to stronger stimuli, such as pinprick. Hypoalgesia, analgesia, is loss of sensation to painful stimuli. 31. Symptoms are also grouped into negative and positive for some mental disorders such as schizophrenia. 32. Positive symptoms are those that are present in the disorder and are not normally experienced by most individuals and reflects an excess or distortion of normal functions. 33. Examples are hallucinations, delusions, and bizarre behavior. Negative symptoms are functions that are normally found but that are diminished or absent. For example, the negative symptoms of schizophrenia include apathy and anhedonia. 33. Dynamic and static. Dynamic symptoms are capable of change depending on circumstance, whereas static symptoms are fixed or unchanging regardless of circumstance. For example, the symptoms of exercise intolerance are dynamic as they are brought on by exercise, but alleviate during rest. Fixed muscle weakness is a static symptom as the muscle will be weak regardless of exercise or rest. A majority of patients with metabolic myopathies have dynamic rather than static findings, typically experiencing exercise intolerance, muscle pain, and cramps with exercise rather than fixed weakness. 34. Those with the metabolic myopathy of McArdle's disease, GSDV, and some individuals with phosphoglycosamidase deficiency, CDG1T/GSDXIV, initially experience exercise intolerance during mild-moderate aerobic exercise, but the symptoms alleviate after 6 to 10 minutes in what is known as second wind. Neuropsychiatric. Neuropsychiatric symptoms are present in many degenerative disorders including dementia and Parkinson's disease. Symptoms commonly include apathy, anxiety, and depression. 35. Neurological and psychiatric symptoms are also present in some genetic disorders such as Wilson's disease. 36. Symptoms of executive dysfunction are often found in many disorders including schizophrenia and ADHD. 37. 38. Radiologic. Radiologic signs are abnormal medical findings on imaging scanning. These include the Mickey Mouse sign and the golden S sign. When using imaging to find the cause of a complaint, another unrelated finding may be found known as an incidental finding. 39. Cardinal. Cardinal signs and symptoms are those that may be diagnostic and pathognomonic of a certainty of diagnosis. Inflammation, for example, has a recognized group of cardinal signs and symptoms. 40. As does exacerbations of chronic bronchitis. 41. And Parkinson's disease. In contrast to a pathognomonic cardinal sign, the absence of a sign or symptom can often rule out a condition. This is known by the Latin term sine qua non. For example, the absence of known genetic mutations specific for a hereditary disease would rule out that disease. 42. Another example is where the vaginal pH is less than 4.5, a diagnosis of bacterial vaginosis would be excluded. 43. Reflexes. A reflex is an automatic response in the body to a stimulus. 44. Its absence, reduced, hypoactive, or exaggerated, hyperactive, response can be a sign of damage to the central nervous system or peripheral nervous system. In the patellar reflex, knee jerk, for example, its reduction or absence is known as Westphal's sign and may indicate damage to lower motor neurons. When the response is exaggerated, damage to the upper motor neurons may be indicated. Citation needed. Facies. A number of medical conditions are associated with a distinctive facial expression or appearance known as a facies. 45. An example is elfin facies, which has facial features like those of the elf, and this may be associated with Williams syndrome or Donahue syndrome. The most well-known facies is probably the Hippocratic facies that is seen on a person as they near death. 46. Anamnestic signs. Anamnestic signs, from anamnestikos, nu alpha mu nu eta sigma tau iota kappa, able to recall to mind, are signs that indicate a past condition. For example, paralysis in an arm may indicate a past stroke. 47. 81. Asymptomatic. Some diseases including cancers and infections may be present but show no signs or symptoms, and these are known as asymptomatic. 9. A gallstone may be asymptomatic and only discovered as an incidental finding. 9. Easily spreadable viral infections such as COVID-19 may be asymptomatic but may still be transmissible. 48. History. Symptomatology. A symptom, from Greek sigma mu pi tau omega mu alpha, accident, misfortune, that which befalls, 49, from sigma upsilon mu pi pi tau omega, I befall, from sigma upsilon nu, together, with and pi pi tau omega, I fall, is a departure from normal function or feeling. Symptomatology, also called semiology, is a branch of medicine dealing with the signs and symptoms of a disease. 50, 51, 52. This study also includes the indications of a disease. 53. It was first described as semiotics by Henry Stubb in 1670, a term now used for the study of sign communication. Citation needed. Prior to the 19th century, there was little difference in the powers of observation between physician and patient. Most medical practice was conducted as a cooperative interaction between the physician and patient. This was gradually replaced by a monolithic consensus of opinion imposed from within the community of medical investigators. 54, 55. Whilst each noticed much the same things, the physician had a more informed interpretation of those things. The physicians knew what the findings meant and the layman did not. 47, 82. Development of medical testing. Further information, medical test. Painting of René Laennec in 1816 using an early method of auscultation on a man with tuberculosis. A number of advances introduced mostly in the 19th century allowed for more objective assessment by the physician in search of a diagnosis, and less need of input from the patient. 54, 55, 56. During the 20th century, the introduction of a wide range of imaging techniques and other testing methods such as genetic testing, clinical chemistry tests, molecular diagnostics, and pathogenomics have made a huge impact on diagnostic capability. 57. In 1761, the percussion technique for diagnosing respiratory conditions was discovered by Leopold Auenbrugger. 58. This method of tapping body cavities to note any abnormal sounds had already been in practice for a long time in cardiology. 58. Percussion of the thorax became more widely known after 1808 with the translation of Auenbrugger's work from Latin into French by Jean-Nicolas Corvisart. 59. In 1819, the introduction of the stethoscope by René Laennec began to replace the centuries-old technique of immediate auscultation, listening to the heart by placing the ear directly on the chest, with mediate auscultation using the stethoscope to listen to the sounds of the heart and respiratory tract. Laennec's publication was translated into English, 1824, by John Forbes. The 1846 introduction by Surgeon John Hutchinson, 1811 to 1861, of the spirometer, an apparatus for assessing the mechanical properties of the lungs via measurements of forced exhalation and forced inhalation. The recorded lung volumes and airflow rates are used to distinguish between restrictive disease, in which the lung volumes are decreased, example, cystic fibrosis, and obstructive diseases, in which the lung volume is normal but the airflow rate is impeded, example, emphysema. Citation needed. The 1851 invention by Hermann von Helmholtz, 1821 to 1894, of the ophthalmoscope, which allowed physicians to examine the inside of the human eye. The, circa 1870, immediate widespread clinical use of Sir Thomas Clifford Allbutt's, 1836 to 1925, 6-inch, rather than 12-inch, pocket clinical thermometer, which he had devised in 1867, 60. The 1882 introduction of bacterial cultures by Robert Koch, initially for tuberculosis, being the first laboratory test to confirm bacterial infections. The 1895 clinical use of X-rays, which began almost immediately after they had been discovered that year by Wilhelm Conrad Röntgen, 1845 to 1923. The 1896 introduction of the sphygmomanometer, designed by Scipione Rivaracci, 1863 to 1937, to measure blood pressure. Diagnosis. The recognition of signs and noting of symptoms may lead to a diagnosis. Otherwise, a physical examination may be carried out and a medical history taken. Further diagnostic medical tests such as blood tests, scans, and biopsies may be needed. An X-ray, for example, would soon be diagnostic of a suspected bone fracture. A noted significance detected during an examination or from a medical test may be known as a medical finding. 61. Examples. See also, List of eponymous medical signs. Further information, List of medical symptoms, medical signs and symptoms. Ascites. Nail clubbing, deformed nails. Cough. Death rattle, last moments of life. Hemoptysis, blood-stained sputum. Jaundice. Organomegaly, an enlarged organ such as the liver, hepatomegaly. Palmar erythema, reddening of hands. Hypersalivation, excessive, saliva. Unintentional weight loss. See also. Icon Medicine Portal. Biomarker, medicine. Focal neurologic signs. A medical test is a medical procedure performed to detect, diagnose, or monitor diseases, disease processes, susceptibility, or to determine a course of treatment. Medical tests such as physical and visual exams, diagnostic imaging, genetic testing, chemical and cellular analysis, relating to clinical chemistry and molecular diagnostics, are typically performed in a medical setting. Types of tests. By purpose. Medical tests can be classified by their purposes, the most common of which are diagnosis, screening and evaluation. Citation needed. Diagnostic. Lung scintigraphy, evaluating lung cancer. A diagnostic test is a procedure performed to confirm or determine the presence of disease in an individual suspected of having a disease, usually following the report of symptoms, or based on other medical test results. 1, 2. This includes posthumous diagnosis. Examples of such tests are using nuclear medicine to examine a patient suspected of having a lymphoma, measuring the blood sugar in a person suspected of having diabetes mellitus after periods of increased urination, Taking a complete blood count of an individual experiencing a high fever to check for a bacterial infection. 1. Monitoring electrocardiogram readings on a patient with chest pain to diagnose or determine any heart irregularities. 3. Screening. Main article, Screening, Medicine. Screening refers to a medical test or series of tests used to detect or predict the presence of disease in at-risk individuals within a defined group such as a population, family, or workforce. 4. 5. Screenings may be performed to monitor disease prevalence, manage epidemiology, aid in prevention, or strictly for statistical purposes. 6. Examples of screenings include measuring the level of TSH in the blood of a newborn infant as part of newborn screening for congenital hypothyroidism. 7. Checking for lung cancer in non-smoking individuals who are exposed to secondhand smoke in an unregulated working environment, and pap smear screening for prevention or early detection of cervical cancer. Citation needed. Monitoring. Main article, Monitoring, Medicine. Some medical tests are used to monitor the progress of or response to medical treatment. By method. Most test methods can be classified into one of the following broad groups. Patient observations, which may be photographed or recorded. Questions asked when taking an individual's medical history. Tests performed in a physical examination. Radiologic tests, in which, for example, X-rays are used to form an image of a body target. These tests often involve administration of a contrast agent. In vivo diagnostics which test in the body, such as manometry. 8. Administering a diagnostic agent and measuring the body's response, as in the gluten challenge test, contraction stress test, bronchial challenge test, oral food challenge, or the ACTH stimulation test. In vitro diagnostics which test a sample of tissue or bodily fluids. 9, 10, such as liquid biopsy. Microbiological culturing, which determines the presence or absence of microbes in a sample from the body, and usually targeted at detecting pathogenic bacteria. Genetic testing. Blood sugar level. 11. Liver function testing. 12. Calcium testing. 12. Testing for electrolytes in the blood, such as sodium, potassium, creatinine, and urea. 13. By sample location. In vitro tests can be classified according to the location of the sample being tested, including blood tests, urine tests, including naked eye exam of the urine, stool tests, including naked eye exam of the feces, sputum, phlegm, including naked eye exam of the sputum. Accuracy and precision. Main article, Accuracy and precision. Accuracy of a laboratory test is its correspondence with the true value. Accuracy is maximized by calibrating laboratory equipment with reference material and by participating in external quality control programs. Precision of a test is its reproducibility when it is repeated on the same sample. An imprecise test yields widely varying results on repeated measurement. Precision is monitored in laboratory by using control material. Detection and quantification. Tests performed in a physical examination are usually aimed at detecting a symptom or sign, and in these cases, a test that detects a symptom or sign is designated a positive test, and a test that indicated absence of a symptom or sign is designated a negative test, as further detailed in a separate section below. A quantification of a target substance, a cell type or another specific entity is a common output of, for example, most blood tests. This is not only answering if a target entity is present or absent, but also how much is present. In blood tests, the quantification is relatively well specified, such as given in mass concentration, while most other tests may be quantifications as well, although less specified, such as a sign of being very pale rather than slightly pale. Similarly, radiologic images are technically quantifications of radiologic opacity of tissues. Citation needed. Especially in the taking of a medical history, there is no clear limit between a detecting or quantifying test versus rather descriptive information of an individual. For example, questions regarding the occupation or social life of an individual may be regarded as tests that can be regarded as positive or negative for the presence of various risk factors, or they may be regarded as merely descriptive, although the latter may be at least as clinically important. Citation needed. Positive or negative. The result of a test aimed at detection of an entity may be positive or negative. This has nothing to do with a bad prognosis, but rather means that the test worked or not, and a certain parameter that was evaluated was present or not. For example, a negative screening test for breast cancer means that no sign of breast cancer could be found, which is in fact very positive for the patient. Citation needed. The classification of tests into either positive or negative gives a binary classification, with resultant ability to perform Bayesian probability and performance metrics of tests, including calculations of sensitivity and specificity. Citation needed. Continuous values. Tests whose results are of continuous values, such as most blood values, can be interpreted as they are, or they can be converted to a binary ones by defining a cutoff value, with test results being designated as positive or negative depending on whether the resultant value is higher or lower than the cutoff. Interpretation. Further information, pre- and post-test probability. In the finding of a pathognomonic sign or symptom, it is almost certain that the target condition is present, and in the absence of finding a sine qua non sign or symptom, it is almost certain that the target condition is absent. In reality, however, the subjective probability of the presence of a condition is never exactly 100% or 0%, so tests are rather aimed at estimating a post-test probability of a condition or other entity. Most diagnostic tests basically use a reference group to establish performance data such as predictive values, likelihood ratios, and relative risks, which are then used to interpret the post-test probability for an individual. In monitoring tests of an individual, the test results from previous tests on that individual may be used as a reference to interpret subsequent tests. Risks. Some medical testing procedures have associated health risks, and even require general anesthesia, such as the mediastinoscopy. 14. Other tests, such as the blood test or pap smear, have little to no direct risks. 15. Medical tests may also have indirect risks, such as the stress of testing, and riskier tests may be required as follow-up for a, potentially, false positive test result. Consult the health care provider, including physicians, physician assistants, and nurse practitioners, prescribing any test for further information. Indications. Each test has its own indications and contraindications. An indication is a valid medical reason to perform the test. A contraindication is a valid medical reason not to perform the test. For example, a basic cholesterol test may be indicated, medically appropriate, for a middle-aged person. However, if the same test was performed on that person very recently, then the existence of the previous test is a contraindication for the test, a medically valid reason to not perform it. Information bias is the cognitive bias that causes healthcare providers to order tests that produce information that they do not realistically expect or intend to use for the purpose of making a medical decision. Medical tests are indicated when the information they produce will be used. For example, a screening mammogram is not indicated, not medically appropriate, for a woman who is dying, because even if breast cancer is found, she will die before any cancer treatment could begin. In a simplified fashion, how much a test is indicated for an individual depends largely on its net benefit for that individual. Tests are chosen when the expected benefit is greater than the expected harm. The net benefit may roughly be estimated by equals delta times minus b underscore n equals backslash delta p backslash times r underscore I backslash times b underscore I h underscore I h underscore t, where bn is the net benefit of performing a test. Lambda p is the absolute difference between pre- and post-test probability of conditions, such as diseases, that the test is expected to achieve. A major factor for such an absolute difference is the power of the test itself, such as can be described in terms of, for example, sensitivity and specificity or likelihood ratio. Another factor is the pretest probability, with a lower pretest probability resulting in a lower absolute difference, with the consequence that even very powerful tests achieve a low absolute difference for very unlikely conditions in an individual, such as rare diseases in the absence of any other indicating sign, but on the other hand, that even tests with low power can make a great difference for highly suspected conditions. The probabilities in this sense may also need to be considered in context of conditions that are not primary targets of the test, such as profile relative probabilities in a differential diagnostic procedure. RE is the rate of how much probability differences are expected to result in changes in interventions, such as a change from no treatment to administration of low-dose medical treatment. For example, if the only expected effect of a medical test is to make one disease more likely compared to another, but the two diseases have the same treatment, or neither can be treated, then, this factor is very low and the test is probably without value for the individual in this aspect. BI is the benefit of changes in interventions for the individual. HI is the harm of changes in interventions for the individual, such as side effects of medical treatment. HT is the harm caused by the test itself. Some additional factors that influence a decision whether a medical test should be performed or not included: cost of the test, availability of additional tests, potential interference with subsequent test, such as an abdominal palpation potentially inducing intestinal activity whose sounds interfere with a subsequent abdominal auscultation, time taken for the test or other practical or administrative aspects. The possible benefits of a diagnostic test may also be weighed against the costs of unnecessary tests and resulting unnecessary follow-up and possibly even unnecessary treatment of incidental findings. 16. In some cases, tests being performed are expected to have no benefit for the individual being tested. Instead, the results may be useful for the establishment of statistics in order to improve health care for other individuals. Patients may give informed consent to undergo medical tests that will benefit other people. Patient expectations. In addition to considerations of the nature of medical testing noted above, other realities can lead to misconceptions and unjustified expectations among patients. These include: different labs have different normal reference ranges, slightly different values will result from repeating a test. Normal is defined by a spectrum along a bell curve resulting from the testing of a population, not by rational, science-based, physiological principles. Sometimes tests are used in the hope of turning something up to give the doctor a clue as to the nature of a given condition, and imaging tests are subject to fallible human interpretation and can show incidentalomas, most of which are benign, will never cause symptoms, and do not require further evaluation, although clinicians are developing guidelines for deciding when to pursue diagnoses of incidentalomas. 17. A blood test is a laboratory analysis performed on a blood sample that is usually extracted from a vein in the arm using a hypodermic needle, or via finger prick. Multiple tests for specific blood components, such as a glucose test or a cholesterol test, are often grouped together into one test panel called a blood panel or blood work. Blood tests are often used in health care to determine physiological and biochemical states, such as disease, mineral content, pharmaceutical drug effectiveness, and organ function. Typical clinical blood panels include a basic metabolic panel or a complete blood count. Blood tests are also used in drug tests to detect drug abuse. Extraction. A venipuncture performed using a vacutainer. A venipuncture is useful as it is a minimally invasive way to obtain cells and extracellular fluid, plasma, from the body for analysis. Blood flows throughout the body, acting as a medium that provides oxygen and nutrients to tissues and carries waste products back to the excretory systems for disposal. Consequently, the state of the bloodstream affects or is affected by many medical conditions. For these reasons, blood tests are the most commonly performed medical tests. 1. If only a few drops of blood are needed, a finger stick is performed instead of a venipuncture. 2. Indwelling arterial, central venous and peripheral venous lines can also be used to draw blood. 3. Phlebotomists, laboratory practitioners and nurses are those in charge of extracting blood from a patient. However, in special circumstances, and/or emergency situations, paramedics and physicians extract the blood. Also, respiratory therapists are trained to extract arterial blood to examine arterial blood gases. 4. 5. Types of tests. Vacutainer tubes used in the collection of blood. During venipuncture, pressure differences between the vein and the vacuum in the vacutainer forces blood into the tube. Biochemical analysis. A basic metabolic panel measures sodium, potassium, chloride, bicarbonate, blood urea nitrogen, BUN, magnesium, creatinine, glucose, and sometimes calcium. Tests that focus on cholesterol levels can determine LDL and HDL cholesterol levels, as well as triglyceride levels. 6. Some tests, such as those that measure glucose or a lipid profile, require fasting or no food consumption 8 to 12 hours prior to the drawing of the blood sample. 7. For the majority of tests, blood is usually obtained from the patient's vein. Other specialized tests, such as the arterial blood gas test, require blood extracted from an artery. Blood gas analysis of arterial blood is primarily used to monitor carbon dioxide and oxygen levels related to pulmonary function, but is also used to measure blood pH and bicarbonate levels for certain metabolic conditions. 8. While the regular glucose test is taken at a certain point in time, The glucose tolerance test involves repeated testing to determine the rate at which glucose is processed by the body. 9. Blood tests are also used to identify autoimmune diseases and immunoglobulin E-mediated food allergies. See also radioallergosorbent test. 10, 11, 18. Normal ranges. Main article, reference ranges for blood tests. Blood tests results should always be interpreted using the ranges provided by the laboratory that performed the test. Example ranges are shown below. Test, 11, 12, low-high unit comments. Sodium Na, 134-145 mol/L. Potassium K, 3.55.0 mol/L. Urea, 2.56.4 mol/L. Blood urea nitrogen, BUN. Urea 1540 mg/dl. Creatinine, male 62-115 mol/L. Creatinine, female 53-97 mol/L. Creatinine, male 0.71.3 mg/dl. Creatinine, female 0.61.2 mg/dl. Glucose, fasting, 3.95.8 mol/L. See also glycated hemoglobin. Glucose, fasting, 70-120 mg/dl. Standard for the reporting and assessment. The Quadas 2 revision is available. 18. List of medical tests. Main article, List of medical tests. See also. Blood culture. Chemical test. Gold standard, test. Medical sign. Molecular diagnostics. Nailbed assessment. Test panel. Point of care testing. EU IVD regulation. Common abbreviations. Upon completion of a blood test analysis, patients may receive a report with blood test abbreviations. Examples of common blood test abbreviations are shown below. Abbreviation, 13, 14, stands for description. HDL high-density lipoprotein level of good cholesterol in the blood, ratio of HDL, LDL is usually more significant than actual values. LDL low-density lipoprotein level of bad cholesterol in the blood, ratio of HDL, LDL is usually more significant than actual values. PV plasma viscosity. Plasma viscometry, PV, is the measurement of the viscosity of blood plasma. The result is a number given in millipascal seconds, m.pa.s, known as the PV, or plasma viscosity. CRP C-reactive protein level of inflammation with the body. If the immune system is fighting an infection or illness, CRP will be higher. CBC. UK, FBC. Complete blood count. UK, full blood count. Analysis of 15 different blood test readings to provide information about overall health. TSH thyroid stimulating hormone. Thyroid regulates the function of metabolism. Low levels can lead to weight loss, while high levels lead to weight gain. PTH parathyroid hormone regulates serum calcium. ESR erythrocyte sedimentation rate indicates the time it takes for red blood cells to move down a tube. This shows signs of inflammation within a body. INR international normalized ratio. This is a blood clotting test. LFT liver function test. This test reveals the levels of waste products, enzymes and proteins that are processed by the liver. Urea and electrolytes. This test is performed to measure the function of kidney. CMP comprehensive metabolic panel. This analysis provides an overall picture of the metabolism and chemical balance of the body. WBC white blood cell, count the level of white blood cells. RBC red blood cell, count the level of red blood cells. HBC hemoglobin level of hemoglobin molecules. HCT hematocrit similar to RBC but in percentage. PLT platelets levels in the blood. Molecular profiles. Protein electrophoresis, general technique, not a specific test. Western blot, general technique, not a specific test. Liver function tests. Polymerase chain reaction, DNA. DNA profiling is today possible with even very small quantities of blood. This is commonly used in forensic science, but is now also part of the diagnostic process of many disorders. Northern blot, RNA. Sexually transmitted diseases. Cellular evaluation. Full blood count, or complete blood count. Hematocrit. MCV, mean corpuscular volume. Mean corpuscular hemoglobin concentration, MCHC. Erythrocyte sedimentation rate, ESR. Cross-matching. Determination of blood type for blood transfusion or transplants. Blood cultures are commonly taken if infection is suspected. Positive cultures and resulting sensitivity results are often useful in guiding medical treatment. A biopsy is a medical test commonly performed by a surgeon, interventional radiologist, or an interventional cardiologist. The process involves extraction of sample cells or tissues for examination to determine the presence or extent of a disease. The tissue is then fixed, dehydrated, embedded, sectioned, stained and mounted. 1. Before it is generally examined under a microscope by a pathologist, it may also be analyzed chemically. When an entire lump or suspicious area is removed, the procedure is called an excisional biopsy. An incisional biopsy or core biopsy samples a portion of the abnormal tissue without attempting to remove the entire lesion or tumor. When a sample of tissue or fluid is removed with a needle in such a way that cells are removed without preserving the histological architecture of the tissue cells, the procedure is called a needle aspiration biopsy. Biopsies are most commonly performed for insight into possible cancerous or inflammatory conditions. History. The Arab physician Abulcasis, 1013–1107, developed one of the earliest diagnostic biopsies. He used a needle to puncture a goiter and then characterized the material. 2. Verification needed. Etymology. The term biopsy reflects the Greek words beta-omicron bios, life, and psi-iota opsis, a site. 3. The French dermatologist Ernest Besnier introduced the word biopsy to the medical community in 1879. 4. Medical use. Cancer. Lung biopsy in a case of suspected lung cancer under control of computed tomography. When cancer is suspected, a variety of biopsy techniques can be applied. An excisional biopsy is an attempt to remove an entire lesion. When the specimen is evaluated, in addition to diagnosis, the amount of uninvolved tissue around the lesion, the surgical margin of the specimen is examined to see if the disease has spread beyond the area biopsied. Clear margins or negative margins means that no disease was found at the edges of the biopsy specimen. Positive margins means that disease was found, and a wider excision may be needed, depending on the diagnosis. Citation needed. When intact removal is not indicated for a variety of reasons, a wedge of tissue may be taken in an incisional biopsy. In some cases, a sample can be collected by devices that bite a sample. A variety of sizes of needle can collect tissue in the lumen, core biopsy. Smaller diameter needles collect cells and cell clusters. Fine needle aspiration biopsy. 5. Pathologic examination of a biopsy can determine whether a lesion is benign or malignant, and can help differentiate between different types of cancer. In contrast to a biopsy that merely samples a lesion, a larger excisional specimen called a resection may come to a pathologist, typically from a surgeon attempting to eradicate a known lesion from a patient. For example, a pathologist would examine a mastectomy specimen, even if a previous non-excisional breast biopsy had already established the diagnosis of breast cancer. Examination of the full mastectomy specimen would confirm the exact nature of the cancer, subclassification of tumor and histologic grading, and reveal the extent of its spread, pathologic staging. Liquid biopsy. Main article, circulating tumor cell. There are two types of liquid biopsy, which is not really a biopsy as they are blood tests that do not require a biopsy of tissue. Circulating tumor cell assays or cell-free circulating tumor DNA tests. 6. These methods provide a non-invasive alternative to repeat invasive biopsies to monitor cancer treatment. 7. Test available drugs against the circulating tumor cells. 8. Evaluate the mutations in cancer and plan individualized treatments. In addition, because cancer is a heterogeneous genetic disease, and excisional biopsies provide only a snapshot in time of some of the rapid, dynamic genetic changes occurring in tumors, liquid biopsies provide some advantages over tissue biopsy-based genomic testing. 9. In addition, excisional biopsies are invasive, can't be used repeatedly, and are ineffective in understanding the dynamics of tumor progression and metastasis. 10. 11. By detecting, quantifying and characterization of vital circulating tumor cells or genomic alterations in CTCs and cell-free DNA in blood, liquid biopsy can provide real-time information on the stage of tumor progression, treatment effectiveness, and cancer metastasis risk. 12. This technological development could make it possible to diagnose and manage cancer from repeated blood tests rather than from a traditional biopsy. 12, 13, 14, 15. Circulating tumor cell tests are already available but not covered by insurance yet at Maintrack and under development by many pharmaceutical companies. Those tests analyze circulating tumor cells, CTCs, 13, 16. Analysis of individual CTCs demonstrated a high level of heterogeneity seen at the single-cell level, 17, for both protein expression and protein localization, and the CTCs reflected both the primary biopsy and the changes seen in the metastatic sites. Citation needed. Analysis of cell-free circulating tumor DNA, cfDNA, has an advantage over circulating tumor cells assays in that there is approximately 100 times more cell-free DNA than there is DNA in circulating tumor cells. 6. These tests analyze fragments of tumor cell DNA that are continuously shed by tumors into the bloodstream. Companies offering cfDNA next-generation sequencing testing include Personal Genome Diagnostics and Guardant Health. 9. These tests are moving into widespread use when a tissue biopsy has insufficient material for DNA testing or when it is not safe to do an invasive biopsy procedure. According to a recent report of results on over 15,000 advanced cancer patients sequenced with the Guardant Health test. 18. A 2014 study of the blood of 846 patients with 15 different types of cancer in 24 institutions was able to detect the presence of cancer DNA in the body. They found tumor DNA in the blood of more than 80% of patients with metastatic cancers and about 47% of those with localized tumors. The test does not indicate the tumor sites or other information about the tumor. The test did not produce false positives. 19. Such tests may also be useful to assess whether malignant cells remain in patients whose tumors have been surgically removed. 20. Up to 30% are expected to relapse because some tumor cells remain. 21. Initial studies identified about half the patients who later relapsed, again without false positives. 19. Another potential use is to track the specific DNA mutations driving a tumor. Many new cancer medications block specific molecular processes. Such tests could allow easier targeting of therapy to tumor. Precancerous conditions. For easily detected and accessed sites, any suspicious lesions may be assessed. Originally, this was skin or superficial masses. X-ray, then later CT, MRI, and ultrasound along with endoscopy extended the range. Citation needed. Inflammatory conditions. A biopsy of the temporal arteries is often performed for suspected vasculitis. In inflammatory bowel disease, Crohn's disease and ulcerative colitis, frequent biopsies are taken to assess the activity of disease and to assess changes that precede malignancy. 22. Biopsy specimens are often taken from part of a lesion when the cause of a disease is uncertain or its extent or exact character is in doubt. Vasculitis, for instance, is usually diagnosed on biopsy. Kidney disease, biopsy and fluorescence microscopy are key in the diagnosis of alterations of renal function. The immunofluorescence plays a vital role in the diagnosis of crescentic glomerulonephritis. Infectious disease, lymph node enlargement may be due to a variety of infectious or autoimmune diseases. Metabolic disease, some conditions affect the whole body, but certain sites are selectively biopsied because they are easily accessed. Amyloidosis is a condition where degraded proteins accumulate in body tissues. In order to make the diagnosis, the gingival transplantation, biopsies of transplanted organs are performed in order to determine that they are not being rejected or that the disease that necessitated transplant has not recurred. Fertility, a testicular biopsy is used for evaluating the fertility of men and find out the cause of a possible infertility, e.g. when sperm quality is low, but hormone levels still are within normal ranges. 23. Failed verification. Biopsied sites. Bone-a-bone biopsy is a procedure in which bone samples are removed to find out if cancer or infection or other abnormal cells are present. A bone biopsy involves the outer layers of bone, unlike a bone marrow biopsy, which involves the innermost part of the bone. Bone biopsy should as rule be done after all necessary imagings performed. Jamshidi needle has replaced the open biopsy and fine needle aspiration. Bone marrow. Since blood cells form in the bone marrow, a bone marrow biopsy is employed in the diagnosis of abnormalities of blood cells when the diagnosis cannot be made from the peripheral blood alone. In malignancies of blood cells, leukemia and lymphoma, a bone marrow biopsy is used in staging the disease. The procedure involves taking a core of trabecular bone using a trephine and then aspirating material. Breast biopsy is often performed to assess or diagnose breast cancer, and can be performed by various methods such as fine needle aspirate, FNA, core needle biopsy, CNB, or surgical removal. 24. Endovascular endothelial cells. A micro 3D printed device adapted for endovascular techniques has been shown to harvest endothelial cells for transcriptomic analysis. 25. Gastrointestinal tract flexible endoscopy enables access to the upper and lower gastrointestinal tract, such that biopsy of the esophagus, stomach and duodenum via the mouth and the rectum, colon and terminal ileum are commonplace. A variety of biopsy instruments, such as the bioptome, may be introduced through the endoscope and the visualized site biopsied. 26. Until recently, the majority of the small intestine could not be visualized for biopsy. The double balloon push-pull technique allows visualization and biopsy of the entire gastrointestinal tract. 27. Needle core biopsies or aspirates of the pancreas may be made through the duodenum or stomach. 28. Lung biopsies of the lung can be performed in a variety of ways depending on the location. Liver and hepatitis. Most biopsies are not used for diagnosis, which generally occurs by other means. Rather, it is used to determine response to therapy, which can be assessed by reduction of inflammation and progression of disease by the degree of fibrosis or, ultimately, cirrhosis. In the case of Wilson's disease, clinicians use biopsies to determine the quantitative copper level. Pancreatic cysts. Endoscopic ultrasound-guided fine needle aspiration, EUSFNA, of cystic lesions, followed by liquid cell analysis, has been used as a diagnostic tool for differentiating benign, potentially malignant, and malignant pancreatic cysts. 29, 30. Through the needle cytologic brushes have been developed for increasing the cellular content in the aspirates. 31, 32, 33, 34. Prostate. Forms of prostate biopsy include transrectal biopsy, transperineal biopsy and transurethral biopsy. Nervous system forms include brain biopsy, nerve biopsy, and meningeal biopsy. Urogenital system forms include renal biopsy, endometrial biopsy and cervical conization. Other sites include lymph node biopsy, muscle biopsy, and skin biopsy. Analysis of biopsied material. After the biopsy is performed, the sample of tissue that was removed from the patient is sent to the pathology laboratory. A pathologist specializes in diagnosing diseases, such as cancer, by examining tissue under a microscope. When the laboratory, see histology, receives the biopsy sample, the tissue is processed and an extremely thin slice of tissue is removed from the sample and attached to a glass slide. Any remaining tissue is saved for use in later studies, if required. Citation needed. The slide with the tissue attached is treated with dyes that stain the tissue, which allows the individual cells in the tissue to be seen more clearly. The slide is then given to the pathologist, who examines the tissue under a microscope, looking for any abnormal findings. The pathologist then prepares a report that lists any abnormal or important findings from the biopsy. This report is sent to the surgeon who originally performed the biopsy on the patient. Citation needed. A medication, also called medicament, medicine, pharmaceutical drug, medicinal drug or simply drug, is a drug used to diagnose, cure, treat, or prevent disease. 1, 2. Drug therapy. Pharmacotherapy is an important part of the medical field and relies on the science of pharmacology for continual advancement and on pharmacy for appropriate management. Drugs are classified in many ways. One of the key divisions is by level of control, which distinguishes prescription drugs, those that a pharmacist dispenses only on the order of a physician, physician assistant, or qualified nurse, from over-the-counter drugs, those that consumers can order for themselves. Another key distinction is between traditional small molecule drugs, usually derived from chemical synthesis, and biopharmaceuticals, which include recombinant proteins, vaccines, blood products used therapeutically, such as IVIG, gene therapy, monoclonal antibodies and cell therapy, for instance, stem cell therapies. Other ways to classify medicines are by mode of action, route of administration, biological system affected, or therapeutic effects. An elaborate and widely used classification system is the Anatomical Therapeutic Chemical Classification System. The World Health Organization keeps a list of essential medicines. Drug discovery and drug development are complex and expensive endeavors undertaken by pharmaceutical companies, academic scientists, and governments. As a result of this complex path from discovery to commercialization, partnering has become a standard practice for advancing drug candidates through development pipelines. Governments generally regulate what drugs can be marketed, how drugs are marketed, and in some jurisdictions, drug pricing. Controversies have arisen over drug pricing and disposal of used drugs. Definition: medication is a medicine or a chemical compound used to treat or cure illness. According to Encyclopaedia Britannica, medication is a substance used in treating a disease or relieving pain. 3. As defined by the National Cancer Institute, dosage forms of medication can include tablets, capsules, liquids, creams, and patches. Medications can be given in different ways, such as by mouth, by infusion into a vein, or by drops put into the ear or eye. A medication that does not contain an active ingredient and is used in research studies is called a placebo. 4. In Europe, the term is medicinal product, and it is defined by EU law as any substance or combination of substances presented as having properties for treating or preventing disease in human beings, or any substance or combination of substances which may be used in or administered to human beings either with a view to restoring, correcting, or modifying physiological functions by exerting a pharmacological, immunological, or metabolic action or to making a medical diagnosis. 536. In the U.S., a drug is a substance, other than food, intended to affect the structure or any function of the body. A substance intended for use as a component of a medicine but not a device or a component, part, or accessory of a device. A substance intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease. A substance recognized by an official pharmacopoeia or formulary. Biological products are included within this definition and are generally covered by the same laws and regulations, but differences exist regarding their manufacturing processes, chemical process versus biological process. 6. Usage. Drug use among elderly Americans has been studied. In a group of 2,377 people with an average age of 71 surveyed between 2005 and 2006, 84% took at least one prescription drug, 44% took at least one over-the-counter, OTC, drug, and 52% took at least one dietary supplement. In a group of 2,245 elderly Americans, average age of 71, surveyed over the period 2010 to 2011, those percentages were 88%, 38%, and 64%. 7. Classification. Main article, Drug Class. One of the key classifications is between traditional small molecule drugs, usually derived from chemical synthesis, and biological medical products, which include recombinant proteins, vaccines, blood products used therapeutically, such as IVIG, gene therapy, and cell therapy, for instance, stem cell therapies. Citation needed. Pharmaceuticals or drugs or medicines are classified into various other groups besides their origin on the basis of pharmacological properties like mode of action and their pharmacological action or activity. 8. Such as by chemical properties, mode or route of administration, biological system affected, or therapeutic effects. An elaborate and widely used classification system is the Anatomical Therapeutic Chemical Classification System, ATC system. The World Health Organization keeps a list of essential medicines. A sampling of classes of medicine includes antipyretics, reducing fever, pyrexia/pyresis, analgesics, reducing pain, painkillers, antimalarial drugs, treating malaria, antibiotics, inhibiting germ growth, antiseptics, prevention of germ growth near burns, cuts, and wounds, mood stabilizers, lithium and valproate, hormone replacements, Premarin, oral contraceptives, Enivid, biphasic pill, and triphasic pill, stimulants, methylphenidate, amphetamine, tranquilizers, meprobamate, chlorpromazine, reserpine, chlordiazepoxide, diazepam, and alprazolam, statins, levastatin, pravastatin, and simvastatin. Pharmaceuticals may also be described as specialty, independent of other classifications, which is an ill-defined class of drugs that might be difficult to administer, require special handling during administration, require patient monitoring during and immediately after administration, have particular regulatory requirements restricting their use, and are generally expensive relative to other drugs. 9. Types of medicines. See also, category drugs by target organ system. The template below is included via a redirect, template, condensed, that is under discussion. See redirects for discussion to help reach a consensus. This section may have too many subsection headers dividing up its content. Please help improve the section by merging similar sections and removing unneeded subheaders. April 2019, learn how and when to remove this template message. For the digestive system. Lower digestive tract, laxatives, antispasmodics, antidiarrheals, bile acid sequestrants, opioids. Upper digestive tract, antacids, reflux suppressants, antiflatulents, antidopaminergics, proton pump inhibitors, PPIs, H2 receptor antagonists, cytoprotectants, prostaglandin analogs. For the cardiovascular system. Affecting blood pressure / antihypertensive drugs, ACE inhibitors, angiotensin receptor blockers, beta blockers, alpha blockers, calcium channel blockers, thiazide diuretics, loop diuretics, aldosterone inhibitors. Coagulation, anticoagulants, heparin, antiplatelet drugs, fibrinolytics, antihemophilic factors, hemostatic drugs. General, beta receptor blockers, beta blockers, calcium channel blockers, diuretics, cardiac glycosides, antiarrhythmics, nitrate, antianginals, vasoconstrictors, vasodilators. HMG-CoA reductase inhibitors, statins, for lowering LDL cholesterol inhibitors, hypolipidemic agents. For the central nervous system. Drugs affecting the central nervous system include psychedelics, hypnotics, anesthetics, antipsychotics, eugeroics, antidepressants, including tricyclic antidepressants, monoamine oxidase inhibitors, lithium salts, and selective serotonin reuptake inhibitors, SSRIs, antiemetics, anticonvulsants/antiepileptics, anxiolytics, barbiturates, movement disorder. Example, Parkinson's disease, drugs, nootropics, stimulants, including amphetamines, benzodiazepines, cyclopyrrolones, dopamine antagonists, antihistamines, cholinergics, anticholinergics, emetics, cannabinoids, and 5-HT, serotonin, antagonists. For pain. See also, analgesic. The main classes of painkillers are NSAIDs, opioids, and local anesthetics. For consciousness, anesthetic drugs. See also, anesthetic. Some anesthetics include benzodiazepines and barbiturates. For musculoskeletal disorders. The main categories of drugs for musculoskeletal disorders are NSAIDs, including COX-2 selective inhibitors, muscle relaxants, neuromuscular drugs, and anticholinesterases. For the eye. Anti-allergy, mast cell inhibitors. Antifungal, imidazoles, polyenes. Antiglaucoma, adrenergic agonists, beta blockers, carbonic anhydrase inhibitors/hyperosmotics, cholinergics, miotics, parasympathomimetics, prostaglandin agonists/prostaglandin inhibitors, nitroglycerin. Anti-inflammatory, NSAIDs, corticosteroids. Antibacterial, antibiotics, topical antibiotics, sulfa drugs, aminoglycosides, fluoroquinolones. Antiviral drugs. Diagnostic. Topical anesthetics, sympathomimetics, parasympatholytics, mydriatics, cycloplegics. General, adrenergic neuron blocker, astringent. For the ear, nose, and oropharynx. Antibiotics, sympathomimetics, antihistamines, anticholinergics, NSAIDs, corticosteroids, antiseptics, local anesthetics, antifungals, and ceraminolytics. For the respiratory system. Bronchodilators, antitussives, mucolytics, decongestants, inhaled and systemic corticosteroids, beta-2 adrenergic agonists, anticholinergics, mast cell stabilizers, leukotriene antagonists. For endocrine problems. Androgens, antiandrogens, estrogens, gonadotropin, corticosteroids, human growth hormone, insulin, antidiabetics, sulfonylureas, biguanide/metformin, thiazolidinediones, insulin, thyroid hormones, antithyroid drugs, calcitonin, diphosphonate, vasopressin analogs. For the reproductive system or urinary system. Antifungal, alkalinizing agents, quinolones, antibiotics, cholinergics, anticholinergics, antispasmodics, 5-alpha reductase inhibitor, selective alpha-1 blockers, sildenafils, fertility medications. For contraception. Hormonal contraception. Ormeloxifene. Spermicide. For obstetrics and gynecology. NSAIDs, anticholinergics, hemostatic drugs, antifibrinolytics, hormone replacement therapy, HRT, bone regulators, beta receptor agonists, follicle-stimulating hormone, luteinizing hormone, LHRH, gammalenic acid, gonadotropin release inhibitor, progestogen, dopamine agonists, estrogen, prostaglandins, gonadorelin, clomiphene, tamoxifen, diethylstilbestrol. For the skin, emollients, antipyretics, antifungals, antiseptics, scabicides, pediculicides, tar products, vitamin A derivatives, vitamin D analogs, keratolytics, abrasives, systemic antibiotics, topical antibiotics, hormones, desloughing agents, exudate absorbents, fibrinolytics, proteolytics, sunscreens, antiperspirants, corticosteroids, immune modulators. For infections and infestations, antibiotics, antifungals, antileprotics, antituberculous drugs, antimalarials, anthelmintics, amoebicides, antivirals, antiprotozoals, probiotics, prebiotics, antitoxins, and antivenoms. For the immune system, vaccines, immunoglobulins, immunosuppressants, interferons, and monoclonal antibodies. For allergic disorders, antiallergics, antihistamines, NSAIDs, medical citation needed, corticosteroids. For nutrition, tonics, electrolytes and mineral preparations, including iron preparations and magnesium preparations, parenteral nutrition, vitamins, anti-obesity drugs, anabolic drugs, hematopoietic drugs, food product drugs. For neoplastic disorders, cytotoxic drugs, therapeutic antibodies, sex hormones, aromatase inhibitors, somatostatin inhibitors, recombinant interleukins, GCSF, erythropoietin. For diagnostics, contrast media. For euthanasia, see also, barbiturate. A euthanaticum is used for euthanasia and physician-assisted suicide. Euthanasia is not permitted by law in many countries, and consequently, medicines will not be licensed for this use in those countries. Administration. Main article, Route of Administration. February 1918 drawing by Marguerite Martin of a visiting nurse in St. Louis, Missouri, with medicine and babies. A single drug may contain single or multiple active ingredients. The administration is the process by which a patient takes medicine. There are three major categories of drug administration: enteral, via the human gastrointestinal tract, injection into the body, and by other routes, dermal, nasal, ophthalmic, otologic, and urogenital. 10. Oral administration, the most common form of enteral administration, can be performed using various dosage forms including tablets or capsules and liquids such as syrup or suspension. Other ways to take the medication include buccally, placed inside the cheek, sublingually, placed underneath the tongue, eye and ear drops, dropped into the eye or ear, and transdermally, applied to the skin. 11. They can be administered in one dose, as a bolus. Administration frequencies, 12, are often abbreviated from Latin, such as every 8 hours reading Q8H from quaque 8 ora. The drug frequencies are often expressed as the number of times a drug is used per day, example, 4 times a day. It specify may include event-related information, example, 1 hour before meals, in the morning, at bedtime, or complementary to an interval, although equivalent expressions may have different implications, example, every 8 hours versus 3 times a day. Citation needed. Drug discovery. Main article, Drug discovery. In the fields of medicine, biotechnology, and pharmacology, drug discovery is the process by which new drugs are discovered. Citation needed. Historically, drugs were discovered by identifying the active ingredient from traditional remedies or by serendipitous discovery. Later, chemical libraries of synthetic small molecules, natural products, or extracts were screened in intact cells or whole organisms to identify substances that have a desirable therapeutic effect in a process known as classical pharmacology. Since sequencing of the human genome, which allowed rapid cloning and synthesis of large quantities of purified proteins, it has become common practice to use high-throughput screening of large compound libraries against isolated biological targets which are hypothesized to be disease-modifying in a process known as reverse pharmacology. Hits from these screens are then tested in cells and then in animals for efficacy. Even more recently, scientists have been able to understand the shape of biological molecules at the atomic level and to use that knowledge to design, see drug design, drug candidates. Citation needed. Modern drug discovery involves the identification of screening hits, medicinal chemistry, and optimization of those hits to increase the affinity, selectivity, to reduce the potential of side effects, efficacy/potency, metabolic stability, to increase the half-life, and oral bioavailability. Once a compound that fulfills all of these requirements has been identified, it will begin the process of drug development prior to clinical trials. One or more of these steps may, but not necessarily, involve computer-aided drug design. Despite advances in technology and understanding of biological systems, drug discovery is still a lengthy, expensive, difficult, and inefficient process with a low rate of new therapeutic discovery. 13. In 2010, the research and development cost of each new molecular entity, NME, was approximately $1.80 billion. 14. Drug discovery is done by pharmaceutical companies, sometimes with research assistance from universities. The final product of drug discovery is a patent on the potential drug. The drug requires very expensive phase 1, 2, and 3 clinical trials, and most of them fail. Small companies have a critical role, often then selling the rights to larger companies that have the resources to run the clinical trials. Drug discovery is different from drug development. Drug discovery is often considered the process of identifying new medicine. At the same time, drug development is delivering a new drug molecule into clinical practice. In its broad definition, this encompasses all steps from the basic research process of finding a suitable molecular target to supporting the drug's commercial launch. Development. Main article, Drug Development. Drug development is the process of bringing a new drug to the market once a lead compound has been identified through the process of drug discovery. It includes preclinical research, microorganisms/animals, and clinical trials, on humans, and may include the step of obtaining regulatory approval to market the drug. 15. 16. Drug development process. Discovery. The drug development process starts with discovery, a process of identifying a new medicine. Development. Chemicals extracted from natural products are used to make pills, capsules, or syrups for oral use. Injections for direct infusion into the blood, drops for eyes or ears. Preclinical research. Drugs go under laboratory or animal testing to ensure that they can be used on humans. Clinical testing. The drug is used on people to confirm that it is safe to use. FDA review. Drug is sent to FDA before launching the drug into the market. FDA post-market review. The drug is reviewed and monitored by FDA for the safety once it is available to the public. Regulation. Main article, Regulation of therapeutic goods. The regulation of drugs varies by jurisdiction. In some countries, such as the United States, they are regulated at the national level by a single agency. In other jurisdictions, they are regulated at the state level, or at both state and national levels by various bodies, as is the case in Australia. The role of therapeutic goods regulation is designed mainly to protect the health and safety of the population. Regulation is aimed at ensuring the safety, quality, and efficacy of the therapeutic goods which are covered under the scope of the regulation. In most jurisdictions, therapeutic goods must be registered before they are allowed to be marketed. There is usually some degree of restriction on the availability of certain therapeutic goods depending on their risk to consumers. Citation needed. Depending upon the jurisdiction, drugs may be divided into over-the-counter drugs, OTC, which may be available without special restrictions, and prescription drugs, which must be prescribed by a licensed medical practitioner in accordance with medical guidelines due to the risk of adverse effects and contraindications. The precise distinction between OTC and prescription depends on the legal jurisdiction. A third category, behind-the-counter drugs, is implemented in some jurisdictions. These do not require a prescription, but must be kept in the dispensary, not visible to the public, and be sold only by a pharmacist or pharmacy technician. Doctors may also prescribe prescription drugs for off-label use, purposes which the drugs were not originally approved for by the regulatory agency. The classification of pharmacotherapeutic referrals helps guide the referral process between pharmacists and doctors. The International Narcotics Control Board of the United Nations imposes a world law of prohibition of certain drugs. They publish a lengthy list of chemicals and plants whose trade and consumption, where applicable, are forbidden. OTC drugs are sold without restriction as they are considered safe enough that most people will not hurt themselves accidentally by taking it as instructed. 17. Many countries, such as the United Kingdom, have a third category of pharmacy medicines, which can be sold only in registered pharmacies by or under the supervision of a pharmacist. Medical errors include overprescription and polypharmacy, misprescription, contraindication, and lack of detail in dosage and administration instructions. In 2000, the definition of a prescription error was studied using a Delphi method conference. The conference was motivated by ambiguity in what a prescription error is and a need to use a uniform definition in studies. 18. Drug pricing. Main articles, prescription costs and pharmacoeconomics. In many jurisdictions, drug prices are regulated. United Kingdom. In the UK, the Pharmaceutical Price Regulation Scheme is intended to ensure that the National Health Service is able to purchase drugs at reasonable prices. The prices are negotiated between the Department of Health, acting with the authority of Northern Ireland and the UK government, and the representatives of the pharmaceutical industry brands, the Association of the British Pharmaceutical Industry, ABPI. For 2017, this payment percentage set by the PPRS will be 4.75%. 19. Canada. In Canada, the Patented Medicine Prices Review Board examines drug pricing and determines if a price is excessive or not. In these circumstances, drug manufacturers must submit a proposed price to the appropriate regulatory agency. Furthermore, the International Therapeutic Class Comparison Test is responsible for comparing the national average transaction price of the patented drug product under review. 20 different countries that the prices are being compared to are the following: France, Germany, Italy, Sweden, Switzerland, the United Kingdom, and the United States. 20. Brazil. In Brazil, the prices are regulated through legislation under the name of Medicamento Genérico, generic drugs, since 1999. 21. India. In India, drug prices are regulated by the National Pharmaceutical Pricing Authority. United States. Main article: Prescription drug prices in the United States. In the United States, drug costs are partially unregulated, but instead are the result of negotiations between drug companies and insurance companies. 22. High prices have been attributed to monopolies given to manufacturers by the government. 23. New drug development costs continue to rise as well. Despite the enormous advances in science and technology, the number of new blockbuster drugs approved by the government per $1 billion spent has halved every 9 years since 1950. 24. Blockbuster drug. Main article: List of largest selling pharmaceutical products. A blockbuster drug is a drug that generates more than $1 billion in revenue for a pharmaceutical company in a single year. 25. Cimetidine was the first drug ever to reach more than $1 billion a year in sales, thus making it the first blockbuster drug. 26. In the pharmaceutical industry, a blockbuster drug is one that achieves acceptance by prescribing physicians as a therapeutic standard for, most commonly, a highly prevalent chronic, rather than acute, condition. Patients often take the medicines for long periods. 27. History. Main article: History of Pharmacy. Prescription drug history. Antibiotics first arrived on the medical scene in 1932 thanks to Gerhard Domach Winkwithefrauen 28, and were coined the wonder drugs. The introduction of the sulfa drugs led to the mortality rate from pneumonia in the U.S. to drop from 0.2% each year to 0.05% by 1939. 29. Antibiotics inhibit the growth or the metabolic activities of bacteria and other microorganisms by a chemical substance of microbial origin. Penicillin, introduced a few years later, provided a broader spectrum of activity compared to sulfa drugs and reduced side effects. Streptomycin, found in 1942, proved to be the first drug effective against the cause of tuberculosis and also came to be the best known of a long series of important antibiotics. A second generation of antibiotics was introduced in the 1940s, aureomycin and chloramphenicol. Aureomycin was the best known of the second generation. Citation needed. Lithium was discovered in the 19th century for nervous disorders and its possible mood-stabilizing or prophylactic effect. It was cheap and easily produced. As lithium fell out of favor in France, valproate came into play. This antibiotic was the origin of the drug that eventually created the mood stabilizer category. Valproate had distinct psychotropic effects that were of benefit in both the treatment of acute manic states and in the maintenance treatment of manic depression illness. Psychotropics can either be sedative or stimulant. Sedatives aim at damping down the extremes of behavior. Stimulants aim at restoring normality by increasing tone. Soon arose the notion of a tranquilizer, which was quite different from any sedative or stimulant. The term tranquilizer took over the notions of sedatives and became the dominant term in the West through the 1980s. In Japan, during this time, the term tranquilizer produced the notion of a psyche stabilizer and the term mood stabilizer vanished. 30. Premarin, conjugated estrogens, introduced in 1942, and Prempro, a combination estrogen-progestin pill, introduced in 1995, dominated the hormone replacement therapy, HRT, during the 1990s. HRT is not a life-saving drug, nor does it cure any disease. HRT has been prescribed to improve one's quality of life. Doctors prescribe estrogen for their older female patients both to treat short-term menopausal symptoms and to prevent long-term diseases. In the 1960s and early 1970s, more and more physicians began to prescribe estrogen for their female patients. Between 1991 and 1999, Premarin was listed as the most popular prescription and best-selling drug in America. 30. The first oral contraceptive, Enivid, was approved by FDA in 1960. Oral contraceptives inhibit ovulation and so prevent conception. Enivid was known to be much more effective than alternatives including the condom and the diaphragm. As early as 1960, oral contraceptives were available in several different strengths by every manufacturer. In the 1980s and 1990s, an increasing number of options arose including, most recently, a new delivery system for the oral contraceptive via a transdermal patch. In 1982, a new version of the pill was introduced, known as the biphasic pill. By 1985, a new triphasic pill was approved. Physicians began to think of the pill as an excellent means of birth control for young women. 30. Stimulants such as Ritalin, methylphenidate, came to be pervasive tools for behavior management and modification in young children. Ritalin was first marketed in 1955 for narcolepsy. Its potential users were middle-aged and the elderly. It was not until sometime in the 1980s along with hyperactivity in children that Ritalin came onto the market. Medical use of methylphenidate is predominantly for symptoms of attention deficit/hyperactivity disorder, ADHD. Consumption of methylphenidate in the U.S. outpaced all other countries between 1991 and 1999. Significant growth in consumption was also evident in Canada, New Zealand, Australia, and Norway. Currently, 85% of the world's methylphenidate is consumed in America. 30. The first minor tranquilizer was meprobamate. Only 14 months after it was made available, meprobamate had become the country's largest-selling prescription drug. By 1957, meprobamate had become the fastest-growing drug in history. The popularity of meprobamate paved the way for Librium and Valium, two minor tranquilizers that belonged to a new chemical class of drugs called the benzodiazepines. These were drugs that worked chiefly as anti-anxiety agents and muscle relaxants. The first benzodiazepine was Librium. 3 months after it was approved, Librium had become the most prescribed tranquilizer in the nation. 3 years later, Valium hit the shelves and was 10 times more effective as a muscle relaxant and anticonvulsant. Valium was the most versatile of the minor tranquilizers. Later came the widespread adoption of major tranquilizers such as chlorpromazine and the drug reserpine. In 1970, sales began to decline for Valium and Librium, but sales of new and improved tranquilizers, such as Xanax, introduced in 1981 for the newly created diagnosis of panic disorder, SORD. 30. Mevacor, levastatin, is the first and most influential statin in the American market. The 1991 launch of Pravachol, Pravastatin, the second available in the United States, and the release of Zocor, Simvastatin, made Mevacor no longer the only statin on the market. In 1998, Viagra was released as a treatment for erectile dysfunction. 30. Ancient pharmacology. Using plants and plant substances to treat all kinds of diseases and medical conditions is believed to date back to prehistoric medicine. Citation needed. The Kahan Gynecological Papyrus, the oldest known medical text of any kind, dates to about 1800 BC and represents the first documented use of any kind of drug. 31. 32. It and other medical papyri describe ancient Egyptian medical practices, such as using honey to treat infections and the legs of bee-eaters to treat neck pains. Ancient Babylonian medicine demonstrated the use of medication in the first half of the 2nd millennium BC. Medicinal creams and pills were employed as treatments. 33. On the Indian subcontinent, the Atharva-Veda, a sacred text of Hinduism whose core dates from the 2nd millennium BC, although the hymns recorded in it are believed to be older, is the first Indic text dealing with medicine. It describes plant-based drugs to counter diseases. 34. The earliest foundations of Ayurveda were built on a synthesis of selected ancient herbal practices, together with a massive addition of theoretical conceptualizations, new nosologies and new therapies dating from about 400 BC onwards. 35. The student of Ayurveda was expected to know 10 arts that were indispensable in the preparation and application of his medicines: distillation, operative skills, cooking, horticulture, metallurgy, sugar. manufacture, pharmacy, analysis and separation of minerals, compounding of metals, and preparation of alkalis. The Hippocratic Oath for physicians, attributed to 5th century BC Greece, refers to the existence of deadly drugs, and ancient Greek physicians imported drugs from Egypt and elsewhere. 36. The Pharmacopoeia de Materia Medica, written between 50 and 70 CE by the Greek physician Pedanius Dioscorides, was widely read for more than 1,500 years. 37. Medieval pharmacology. Al-Kindi's 9th century AD book, De Gradibus and Ibn Sina, Avicenna, the Canon of Medicine, covers a range of drugs known to the practice of medicine in the medieval Islamic world. Medieval medicine of Western Europe saw advances in surgery compared to previously, but few truly effective drugs existed, beyond opium, found in such extremely popular drugs as the Great Rest of the Antidotarium Nicolai at the time, 38, and quinine. Folklore cures and potentially poisonous metal-based compounds were popular treatments. Theodoric Borgognoni, 1205–1296, one of the most significant surgeons of the medieval period, responsible for introducing and promoting important surgical advances including basic antiseptic practice and the use of anesthetics. Garcia de Orta described some herbal treatments that were used. Vague. Modern pharmacology. For most of the 19th century, drugs were not highly effective, leading Oliver Wendell Holmes Sr. to famously comment in 1842 that if all medicines in the world were thrown into the sea, it would be all the better for mankind and all the worse for the fishes. 27, 21. During the First World War, Alexis Carrel and Henry Dakin developed the Carrel-Dakin method of treating wounds with an irrigation, Dakin solution, a germicide which helped prevent gangrene. In the interwar period, the first antibacterial agents such as the sulfa antibiotics were developed. The Second World War saw the introduction of widespread and effective antimicrobial therapy with the development and mass production of penicillin antibiotics, made possible by the pressures of the war and the collaboration of British scientists with the American pharmaceutical industry. Medicines commonly used by the late 1920s included aspirin, codeine, and morphine for pain, digitalis, nitroglycerin, and quinine for heart disorders, and insulin for diabetes. Other drugs included antitoxins, a few biological vaccines, and a few synthetic drugs. In the 1930s, antibiotics emerged, first sulfa drugs, then penicillin and other antibiotics. Drugs increasingly became the center of medical practice. 27, 22. In the 1950s, other drugs emerged including corticosteroids for inflammation, Rauwolfia alkaloids as tranquilizers and antihypertensives, antihistamines for nasal allergies, xanthines for asthma, and typical antipsychotics for psychosis. 27, 23–24. As of 2007, thousands of approved drugs have been developed. Increasingly, biotechnology is used to discover biopharmaceuticals. 27. Recently, multidisciplinary approaches have yielded a wealth of new data on the development of novel antibiotics and antibacterials and on the use of biological agents for antibacterial therapy. 39. In the 1950s, new psychiatric drugs, notably the antipsychotic chlorpromazine, were designed in laboratories and slowly came into preferred use. Although often accepted as an advance in some ways, there was some opposition, due to serious adverse effects such as tardive dyskinesia. Patients often opposed psychiatry and refused or stopped taking the drugs when not subject to psychiatric control. Governments have been heavily involved in the regulation of drug development and drug sales. In the U.S., the elixir sulfanilamide disaster led to the establishment of the Food and Drug Administration, and the 1938 Federal Food, Drug, and Cosmetic Act required manufacturers to file new drugs with the FDA. The 1951 Humphrey-Durham Amendment required certain drugs to be sold by prescription. In 1962, a subsequent amendment required new drugs to be tested for efficacy and safety in clinical trials. 27, 24–26. Until the 1970s, drug prices were not a major concern for doctors and patients. As more drugs became prescribed for chronic illnesses, however, costs became burdensome, and by the 1970s nearly every U.S. state required or encouraged the substitution of generic drugs for higher-priced brand names. This also led to the 2006 U.S. law, Medicare Part D, which offers Medicare coverage for drugs. 27, 28–29. As of 2008, the United States is the leader in medical research, including pharmaceutical development. U.S. drug prices are among the highest in the world, and drug innovation is correspondingly high. In 2000, U.S.-based firms developed 29 of the 75 top-selling drugs. Firms from the second-largest market, Japan, developed 8, and the United Kingdom contributed 10. France, which imposes price controls, developed 3. Throughout the 1990s, outcomes were similar, 27, 30 to 31. Controversies. Controversies concerning pharmaceutical drugs include patient access to drugs under development and not yet approved, pricing, and environmental issues. Access to unapproved drugs. Main article, Expanded Access. Governments worldwide have created provisions for granting access to drugs prior to approval for patients who have exhausted all alternative treatment options and do not match clinical trial entry criteria. Often grouped under the labels of compassionate use, expanded access, or named patient supply, these programs are governed by rules which vary by country defining access criteria, data collection, promotion, and control of drug distribution. 40. Within the United States, pre-approval demand is generally met through treatment IND, investigational new drug applications, INDs, or single-patient INDs. These mechanisms, which fall under the label of expanded access programs, provide access to drugs for groups of patients or individuals residing in the U.S. Outside the U.S., named patient programs provide controlled, pre-approval access to drugs in response to requests by physicians on behalf of specific, or named, patients before those medicines are licensed in the patient's home country. Through these programs, patients are able to access drugs in late-stage clinical trials or approved in other countries for a genuine, unmet medical need, before those drugs have been licensed in the patient's home country. Citation needed. Patients who have not been able to get access to drugs in development have organized and advocated for greater access. In the United States, ACT UP formed in the 1980s, and eventually formed its Treatment Action Group in part to pressure the U.S. government to put more resources into discovering treatments for AIDS and then to speed release of drugs that were under development. 41. The Abigail Alliance was established in November 2001 by Frank Burroughs in memory of his daughter, Abigail. 42. The alliance seeks broader availability of investigational drugs on behalf of terminally ill patients. In 2013, BioMarin Pharmaceutical was at the center of a high-profile debate regarding expanded access of cancer patients to experimental drugs. 43, 44. Access to medicines and drug pricing. Main articles, Essential Medicines and Societal Views on Patents. Essential medicines, as defined by the World Health Organization, WHO, are those drugs that satisfy the health care needs of the majority of the population. They should therefore be available at all times in adequate amounts and in appropriate dosage forms, at a price the community can afford. 45. Recent studies have found that most of the medicines on the WHO Essential Medicines list, outside of the field of HIV drugs, are not patented in the developing world, and that lack of widespread access to these medicines arise from issues fundamental to economic development, lack of infrastructure and poverty. 46. Medicines Sans Frontieres also runs a campaign for access to essential medicines campaign, which includes advocacy for greater resources to be devoted to currently untreatable diseases that primarily occur in the developing world. The Access to Medicine Index tracks how well pharmaceutical companies make their products available in the developing world. Citation needed. World Trade Organization negotiations in the 1990s, including the TRIPS Agreement and the Doha Declaration, have centered on issues at the intersection of international trade in pharmaceuticals and intellectual property rights, with developed world nations seeking strong intellectual property rights to protect investments made to develop new drugs, and developing world nations seeking to promote their generic pharmaceuticals industries and their ability to make medicine available to their people via compulsory licenses. Some have raised ethical objections specifically with respect to pharmaceutical patents and the high prices for drugs that they enable their proprietors to charge, which poor people around the world cannot afford. 47, 48. Critics also question the rationale that exclusive patent rights and the resulting high prices are required for pharmaceutical companies to recoup the large investments needed for research and development. 47. One study concluded that marketing expenditures for new drugs often doubled the amount that was allocated for research and development. 49. Other critics claim that patent settlements would be costly for consumers, the healthcare system, and state and federal governments because it would result in delaying access to lower-cost generic medicines. 50. Novartis fought a protracted battle with the government of India over the patenting of its drug, Gleevec, in India, which ended up in a Supreme Court in a case known as Novartis versus Union of India and others. The Supreme Court ruled narrowly against Novartis, but opponents of patenting drugs claimed it as a major victory. 51. Environmental issues. Main article: Environmental impact of pharmaceuticals and personal care products. The environmental impact of pharmaceuticals and personal care products is controversial. PPCPs are substances used by individuals for personal health or cosmetic reasons and the products used by agribusiness to boost growth or health of livestock. PPCPs comprise a diverse collection of thousands of chemical substances, including prescription and over-the-counter therapeutic drugs, veterinary drugs, fragrances, and cosmetics. PPCPs have been detected in water bodies throughout the world, and ones that persist in the environment are called environmental persistent pharmaceutical pollutants. The effects of these chemicals on humans and the environment are not yet known, but to date there is no scientific evidence that they affect human health. 52. See also: adherence, deprescribing, drug nomenclature, list of drugs, list of pharmaceutical companies, orphan drug, overmedication, pharmaceutical code, pharmacy.